today's lecture is very, very important. So you guys should understand from the very basics. We have already discussed the basic concept of regulation of the hypertension in our previous lecture. And this is the beauty of teaching you the modular system, because you guys are already familiar with the basics, how the blood pressure is being regulated by our body, and those basic mechanisms which we have already discussed in our physiology section. So here what we do, we are just focusing on those things, and then we will be moving on into the pathophysiology, and followed by discussing some of the I'm really sorry for the disturbance, because I don't know what's the problem with my WhatsApp, so I'm going to turn off that. So what today, this is one of the important things, and see here we have got a normal blood pressure. If you see here, this is our normal blood pressure. It either gets down, go down and become very low, and either it can go into the red side, which is very high. Both are dangerous. So we have to keep our blood pressure in this normal range. We don't have to take it down too much down, and we don't have to bring it too up that it can cause morbidity and mortality to your patients. Okay. So for the definition of the hypertension, what we have two of the most authentic guidelines in the world. So we are following these guidelines, and one of them is GNC. This is Joint National Committee. And another guidelines which we usually follow is American Heart Association. So these two guidelines are very, very important to be followed. So first of all, we have a normal blood pressure. Then we have pre-hypertension, we have stage 1 hypertension and stage 2 hypertension. So these definition and videos are extremely important to be remembered. Somebody has, please turn off your mic. Somebody is creating problem here. Or either I'll do that. Muhammad Nasir, please turn off your mic. I have already told you guys that you should be very careful with your mics, that it causes disturbance to the rest of the people. Okay, so we have already talked about the normal blood pressure. We have two sides of blood pressure. We have talked about this in our physiology section. We have systolic blood pressure, whenever our heart is in the systole and it does not contract. Muhammad Nasir, kindly mute your mic. What are you doing, man? Okay, I'm really sorry for the disturbance. So do you guys have my voice? If yes, then please write me in the comment section, because somebody was creating problem. Okay, that's nice. Thank you. Okay, we have normal blood pressure. Do you see the cursor of the mouse that I'm following, that I'm moving it here and there? If you guys see the cursor, okay, thank you so much. Okay, so we have normal blood pressure, which is systolic blood. I have already told you that we have two phases of the heart in the cardiac cycle. One is the systole and another is our diastole. So according to GNC, or Joint National Committee guidelines, our normal blood pressure, our systolic blood pressure should be less than 120 millimeter of mercury, and our diastolic blood pressure should be less than 80 millimeter of mercury. So this is the standard. If you have blood pressure which is less than 120 systolic and less than 80 millimeter of mercury diastolic, this is considered as a normal blood pressure. So after that, what we have the pre-hypertensive stage. And that is actually from 120 to 139 millimeter of mercury. This systolic, if the systolic blood pressure is 120 to 139, this is called pre-hypertension phase. And if your systolic or diastolic blood pressure is 80 to 89 millimeter of mercury, we call it, this is our pre-hypertensive stage. So we can have either systolic hypertension, we can have diastolic hypertension, or we can call it isolated So if only blood pressure is increased in systole, or your systolic blood pressure is increased, then we call it isolated systolic hypertension. Or if your diastolic blood pressure is increased, we call it isolated diastolic hypertension. If both are increased, then we call it hypertension simply. So the prehypertensive phase, we have already talked about this. We have a normal blood pressure, and then we have stage 1 hypertension. So according to GNC, stage 1 hypertension is 140 to 159. Systolic 140 to 159 systolic blood pressure is stage 1 hypertension, or diastolic 90 to 99. And then we have stage 2 hypertension, which is 160 or greater. If it is 160 or more, we call it stage 2 hypertension. And if your diastolic blood pressure is more than 90 or greater than 90, then we call it, this is our diastolic hypertension. So these are actually the GNC guidelines, Joint National Committee guidelines. So we have to follow this. And then we have American Heart Association. There are certain guidelines. You can have American guidelines, you can have Canadian guidelines, NICE guidelines, which is usually followed in the UK. So you can follow any one of them. They are the standard guidelines. You have to follow one of them. So we have American Heart Association guidelines. In American Heart Association, what they do, they usually eliminated the classification of prehypertension. This is not here. So they have either elevated blood pressure or they have stage 1 hypertension. So in elevated hypertension, they actually, what they do, they eliminated the prehypertension phase and they divided into these two. And this is elevated BP with systolic blood pressure of 120 to 129 millimeter of mercury, and diastolic blood pressure of less than 80 millimeter of mercury. We call it elevated blood pressure or elevated hypertension. And then we have stage 1 hypertension, and in stage 1 hypertension we have systolic blood pressure 130 to 139 millimeter of mercury, and our diastolic blood pressure will be 80 to 89 millimeter of mercury. So this is straightforward and very simple. If you guys still have any problem, I can explain it in our national languages. If no, then we can move on. Do you guys understand this? This is, I guess, very simple. So we have to move forward to the next section. Okay, I'll explain in one of the national languages that you can understand. Okay. متوجه شي منګه چې د دوه ګایډلاینز دي په دنیا کې، یو ته GNC او یو بل ته American Heart Association. دا ډېر ریلایبل دي. نور هم شته نایس ګایډلاینز دي American Heart Associations نه بغیر او د GNC نه بغیر. نایس ګایډلاینز چې په UK کې خلک ډېر زیات فالو کوي، او په کاناډا کې چې د کینیډین ګایډلاینز دي هغه یې فالو کوي. نو په دنیا کې د هر ملک چې دا هغه ځان ته د سټانډرډ کنټریز چې دوی ځان ته خپل ګایډلاینز جوړ کړي دي. نو د GNC ګایډلاینز چې دي دا هغه چې دي دا په دریو سلورو برخو باندې ویل شي. اول نورمال نورمال بلډ پریشر چې هغه چې دا باید د 100 نه سیستولیک بلډ پریشر او د 80 نه باید ډایسټولیک بلډ پریشر کم وي. د تمنګ چې وي د تمنګ نورمال بلډ پریشر وي. او پری هایپرټنشن هغه ته وي چې هغه کې بلډ پریشر سیستولیک چې کم د 100 نه تر 109 پورې شي او ډایسټولیک د 80 نه تر 90 پورې. سټیج 1 چې کم دی هغه کې 140 نه تر 150 پورې کچېره سیستولیک بلډ پریشر شي هغه تمنګ هغه وي سټیج 1 هایپرټنشن وي. او 90 نه تر 99 پورې کچېره بلډ پریشر هغه تمنګ سټیج 1 هایپرټنشن. ډایسټولیک به د 90 نه تر 99 پورې او سیستولیک به د 140 نه تر 150 پورې د تمنګ سټیج 1 وي. بیا ورته سټیج 2 دی. په سټیج 2 کې چې دا کنه تاسو سیستولیک بلډ پریشر بای 116 نه زیات کیږي، 180 نه چې جګ شي یا 180 شي، نو د تمنګ سوي د تمنګ غوي سټیج 2 هایپرټنشن وي. او کچېره ډایسټولیک بلډ پریشر دی د 90 نه زیات سي هغه تمنګ سوي هغه تمنګ هم هغه وي سټیج 2 هایپرټنشن وي. خو په دې کې بیا کې دی چې یوازې ستاسو سیستولیک بلډ پریشر زیاتی یا کې دی چې یوازې ډایسټولیک بلډ پریشر زیاتی، نو بیا هغه تمنګ څه ټرمینالوژي ورکو د تمنګ آیسولیټډ سیستولیک هایپرټنشن یا آیسولیټډ مطلب چې په تنها ډول باندې. آیسولیټډ مطلب د تنهایی په تنها کچېره سیستولیک زیات شي نو آیسولیټډ هغه ته وایي چې آیسولیټډ سیستولیک، او کچېره ډایسټولیک زیات شي نو هغه ته آیسولیټډ ډایسټولیک. نو دا چې دی د GNC ګایډلاینز دي. امریکن هارت اسوسییشن چې دا هغه د پری هایپرټنشن راوسته او صرف دوه برخې ورکړي. یو ته وی الیویټډ بلډ پریشر چې هغه کې سیستولیک 140 نه تر 129 millimeter of mercury او diastolic چې دا غدا اتیاو نه کم شي. stage 1 hypertension چې دا کې بچي systolic blood pressure به یو سل ډیر شنه تر یو سل نه ډیر شو پوری او diastolic به اتیاو نه تنه اتیاو پوری. نو دا چې دا بیسیک دوه ګایډلاینز دي چې موږ په دنیا کې فالو کوو نو دنه ها next چې کوم زمون portion ده کچېری تاسو په یادي ما کچېری تاسو په یاد وي ما تاسو ته په شروع کې ویلی وو چې بعض فیکټرز دي چې هغه کنټریبیوټ کوي چې شته هغه هایپرټنشن ته کنټریبیوټ کوي. نو if you guys remember, we talked about main arterial pressure. We said that main arterial pressure is totally dependent on cardiac output and total peripheral resistance. Okay, so our main arterial pressure is totally dependent on cardiac output and total peripheral resistance. So what determines our cardiac output? It is determined by our stroke volume and heart rate, and these are the two things that determine your cardiac output. And what determines your stroke volume? It is, we have already discussed these things, and it is also given in your first aid that C is for contractility. What is C? This is for contractility, and this A is for afterload, and P is for preload. These are the things that actually are determining your stroke volume, and then stroke volume and heart rate are determining your cardiac output, and TPR is totally dependent on a systemic vascular resistance and vascular tone. These are the two things that are controlling your total peripheral resistance. The فارسی براتان تشریح میکنم. خب یک چیز ما داشتیم به نام main arterial pressure. امو اوسط فشار خون که است او توسط دو چیزا کنترل میشه. یکی که است کاردیک اوتپوت است و دومش که است چی است total peripheral resistance است که TPR برش میگه. این دو چیزا که است یا چی میکنن این اوسط فشار ما را کنترل میکنن و وقتی که باز این کاردیک اوتپوت ما که است این توسط دو چیز کنترل میشه. یکی stroke volume است و دومش که است و heart rate است. stroke volume and heart rate این دو چیزا است که چی میکنه کنترل میکنه کاردیک اوتپوت ما. باز stroke volume که است و توسط این دو چیز سه چیز کنترل میشه. یکی contractility است، یکی afterload است، دیگه preload است. اگر شما لکچر فیزیولوژی ما را فالو کرده باشین دیگه این چیزا را میفهمین و اگر شما این چیزا را بفهمین دیگه من مطمئن هستم که براتون ده هیچ چیز مشکل نمیمونه. اگر این چیزا را شما میفهمین دیگه من مطمئن هستم که شما ان شاء الله هیچ مشکل پیدا نمیکنین. در باقی مانده لکچر که ما داریم با این چیزا شما میفهمین. کاردیاک اوتپوت هم میشناسین، شما توتال پریفرال رزिस्टنس هم میشناسین، شما استروک والیم هم میشناسین، افترلود پریلود همه چیز هم میشناسین. یکی از دوستا برای من کاردیک اوتپوت تعریف کنین که کاردیک اوتپوت چی است. با انگلیسی تعریف کنین لطفاً.
The blood of when the heart in 1 minute pump the quantity of the blood when pumped in 1 minute by heart. It's called cardiac output.
This is our cardiac output. Cardiac output is the amount of blood which is pumped by our heart per minute. This is actually called cardiac output. And there are two things which actually determine our cardiac output. What are those two things? This is stroke volume, and then we have heart rate. And these two things are actually maintaining our cardiac output. So the stroke volume is then what does maintain our stroke volume? This is the contractility. Actually, what is contractility? Contractility is the ability of the heart to contract, and this is our contractility. And afterload is the load which the heart faces to overcome and push the blood out of the heart. I'm really sorry, I have a call I have to attend it, and then we can continue the call. Hello. زه تاسو ته بیرته ټلیفون کوم، زه لږ مصروف یم. I'm really sorry. دیگه این چیزا که هست ایره اگه شما میفهمین براتون بسیار آسان میشه باقی مانده لکچر ما. خب میریم به next portion. main arterial pressure هم میفهمیم، cardiac output هم میفهمیم، TPR هم میفهمیم، contractility after load preload year हमारा में फॉर्म स्ट्रोक वाले में हार्ट रेट अगर ये चीज़ और शमा बो फॉर्म इंदिगा हाइपरटेंशन बरतान बिस्योर आसान में you can say حلوا میشه براتون. خب اصلا ما چند رقم فشار داریم. یکی را میگیم ما پرایمری هایپرتنشن و دیگه‌ش میگیم ما سکندری هایپرتنشن. پرایمری هایپرتنشن ما اسنشیال هایپرتنشن هم میگیم. کدام هایپرتنشن میگیم؟ میرا ما اسنشیال هایپرتنشن میگیم. اسنشیال اونو هایپرتنشن است که کدام خاص علت تش معلوم نیست. There is no specific cause. Can you guys hear me?
Yes, sir.
Okay.
Yes, sir.
Somebody was saying that I can't hear you.
Yes.
So we have primary hypertension when we have secondary hypertension. Primary hypertension, in primary hypertension, we usually does not have any identifiable cause. There are certain factors which are contributing to the development of the primary hypertension. One are the genetic factors, and the second is environmental factors. So these factors are actually contributing into the development of primary hypertension. No identifiable cause. And this is the majority of the cases. Like you can have in 90 to 95% cases, you will have primary hypertension that we don't have identifiable cause. And it is usually in old age. Like you will have a patient who is 35 or 40 years old and he or she is presenting to you with hypertension. So these patients are actually what they are old age, and they have a genetic or family history of hypertension, and these people have some of the risk factors that they develop hypertension. And the secondary hypertension, we have a specific cause for that, and these are very less in number. Like you can have 5 or 10% people who will develop secondary hypertension. We will discuss both of these types of hypertension in details, and later on I have brilliantly explained it to you. Inshallah, you will step by step understand the causes and then the factors and how we can manage these two types of hypertension and how we can treat them. اوکی خب ما براتون گفتم که ما دو تایپ هایپرتنشن داریم. یکیش که است و چی است؟ پرایمری هایپرتنشن است که اسنشیال هایپرتنشن هم میگه. بعضی کدام وجوهاتش بسیار کم معلوم است. دیگه عموما ژنتیکی و محیطی امو تاثیرات است که او بالای مریض میایه و او پرون میشه که دیولپ کنه هایپرتنشن. اما عموما این مریضا هستن که در فامیلشان زیاد یا فامیلی هیستوری دارن که در فامیلشان یک کس هایپرتنشن داره، مادرشان یا پدرشان. و یا هم کدام فاکتورایی را که مثلا و دیگه ممکن دی چی باشه که تقریبا 90 تا 95% بسیار کامن است. تقریبا 90 تا 95% کیس اینمی پرایمری هایپرتنشن است. و دی چی میشه عموما که دی مختلف فاکتوراست که ایره چیز میکنه. یا یک نفر است مثلا سموکینگ میکنه، یک نفر است الکل میخوره، زیاد مینوشه، و یا یک نفر است که مثلا او زیاد استرس میگیره. تایپ A پرسونالیتی است که دو بسیار استرس کامن است. مثلا maybe I'm one of those people who are getting more stress. اما چی است که اونو مردم هستن که و زیاد استرس میگیرن، زیاد الکل، cigarette smoking, they have sedentary lifestyle. We will be discussing all these things in a minute. و دیگه چی است؟ سکندری هایپرتنشن اونو است که دو یک علت داشته باشه. مثلا یک علت است، یک دیزیز است که او را کاز میکنه. یکی از اگزامپلش هم براتون کوشین سندروم گفتم میتونین، کون سندروم یا هایپر الدوسترینیزم است، یا مثلا یک کس هایپرتایروید است یا هایپر پاراتایروید است. بسیار علت است. به کلیش ان شاء الله ده سلاید آینده براتون ما تشریح میکنم ان شاء الله که فهمیده باشین این مهمه چیز. که څوک نه پوښوي چې پښتو کې تاسو ته تشریح کړم. Okay, that's nice. Well done. ډېر ښه. Next Manglaru. Okay, we have already talked about these basic things, that the primary or essential hypertension is 90 to 95%. It usually develops due to environmental and genetic causes that we will be discussing them in a second. Most common is usually in old people, like 25 or above people, or they might be above 50 or 50. So ages usually more than 25, and they might be 30, 40, 50, 60, or mostly you can say they are old age patients. And there are certain mechanisms that are involved in development of primary hypertension. One is increase in sympathetic nervous system activity. So what does sympathetic nervous system do? Whenever there is increased sympathetic activity, what happens that catecholamine are released in those are epinephrine, norepinephrine. They are acting into different areas of the body, like they can affect on your vessels, and they cause intense vasoconstriction, and they can affect on your heart and on SA node, nodal tissue and non-nodal tissue. They can increase your contractility of the heart, and they can increase your SA nodal firing and increase your heart rate. So these are all those things. And once we have already talked about these things, is that the most important thing in regulation of the main arterial pressure are TPR and your cardiac output. And these are those things. And whenever your heart rate goes up, it causes increase in your cardiac output. And whenever there is increase in cardiac contractility, and it leads to increase in a cardiac output. And whenever there is increase in vasoconstriction, what does it do? It increases your TPR. So when the cardiac output increases, your TPR increases, they usually causes increases your blood pressure. And the second thing we have is renin, angiotensin, aldosterone system, which we have already discussed in our physiology section. That what does renin, angiotensin, aldosterone system do? The net effect I'll explain you, because rest of the thing I have already explained to you guys. That renin is released from the juxtaglomeralar nephritis and apparatus. In that apparatus, usually when there is decreased blood pressure, it causes a release of renin. And renin goes and activates through the certain pathways, activates and converts angiotensin into angiotensin 1 into angiotensin into angiotensin 2, which is one of the potent vasoconstrictor. And similarly, what does angiotensin 2 do? It usually goes to kidneys and release suprarenal gland, and releases aldosterone, and also in the posterior pituitary it releases EDH. And these combinedly, what does they do? They increases the sodium and water retention, and also they causes potent vasoconstriction, activates sympathetic nervous system activity. And the combined effect is what they does, they increases blood volume, venous return, cardiac output, and leads to the hypertension. And then we have increased sodium retention, which is the similarly I have explained before. Whenever there is sodium retention, it follows water. The blood volume increases, and whenever the blood volume increases venous return. And when the venous return is increased, the proper filling preload increases, and it increases your cardiac output and increases your blood pressure. So in old age, what happens? This is also common. In old age, there is more elastin. The elasticity will be decreased. Elastin will be decreased, and collagen level will be increased. And whenever there is collagen, it decreases compliance of the vessels. And whenever compliance of the vessels are decreased, they leads to hypertension. So these are the basic mechanisms which are involved in the development of primary hypertension. Are you guys clear about this? If not, then we can explain it in our national languages. If yes, then write me in the comment section that we can move on. I think these are the things that we have already discussed. If any one of you have any problem, if any one of you has any problem, you can write me in the comment section. I can explain it in our national languages. Okay, that's nice. Do you guys hear me?
Yes, sir, we can hear you.
Okay. I'm really sorry, there is problem with my computer. So okay, nice. So we'll be moving to the next section. If you have question, you can hold on. I'll answer all your questions, inshallah, at the end of the section. So we have already talked about the risk factors which are causing hypertension. One of them was old age. You guys already know about the mechanism. I have already explained it to you, that in old age, what happens, that there is increase in collagen and decrease in elastin. And the second thing is what happens that there is aortic causes aortic stenosis. Aortic stenosis is the other cause, and the third cause is that the peripheral vascular resistance gets increased. These are the three possible ways that causes hypertension in old age. And then what we have smoking. In smoking, what happens, you guys know that smoking have nicotine. It acts as a adrenergic agonist. What does it do? It is mediating systemic and local catecholamines release. And whenever there is release of catecholamine, we already discussed the role of epinephrine and norepinephrine. They are affecting on the heart and your blood vessels. They are causing vasoconstriction, increasing TPR, and they are acting on other side in your heart. Whenever they are acting on your heart, they are increasing contractility of the heart. So these are basically combinedly increasing the blood pressure. And sedentary lifestyle, those who are not doing regular exercises and activities, and they're sleeping there and they're eating a lot of potatoes and all those things which are increasing their weight, and they're causing atherosclerosis. So those people are prone to hypertension. And then we have obesity. Obesity is very common, you guys know, in the United States and in our environment, so many people. So we have two hormones in our body. One is leptin and another is ghrelin, if you guys are familiar with that or not. But we have two hormones. One is leptin and another is ghrelin. Ghrelin makes you grow. So ghrelin starts with G and leptin ends with TIN, thin. So anything, as leptin ends with TIN, I remember this from this basic mnemonic that leptin makes you thin and ghrelins make you grow. So ghrelin actually, and those who has obesity, and these people, the amount of hormone ghrelin is much more higher than those normal individuals. So what it does, it usually causes leptin resistance, and leptin usually causes decreases TPR, and whenever there is decrease in amount of leptin, your peripheral resistance increases, and whenever the peripheral resistance increases, heart has to pump with a lot of pressure to overcome that resistance. So this is the basic mechanism in obesity that leads to the development of hypertension. And we have another thing which is called alcohol. Alcohol is very common in the United States in the people who are living in the West. And this is a significant cause of increased blood pressure. So what alcohol does to the body, it actually activates your sympathetic nervous system activity, and rest of the story I have already explained how sympathetic activity increases your blood pressure through the increasing heart rate, through increasing contractility and TPR. So there's the net effect is increasing your blood pressure. And the second thing we have is renin, and they usually go and act on the adrenal gland and release some of the certain hormones like cortisol, and also it acts on the kidney and releases the renin. And when renin releases, it activates renin, angiotensin, aldosterone system, and all those mechanisms which we have already explained before in physiology and today as well. They are combinedly affecting your blood volume, your contractility, and your total peripheral resistance, and they are combinedly affecting and increasing your blood pressure. And one another mechanism that is very famous about the alcohol, they usually increases the intracellular calcium amounts. And whenever, calcium is a supplementary for the contraction of the blood vessels in the myocytes. So whenever there is increased calcium, they leads to the more contraction of the cardiac myocytes and also intense constriction of the vasoconstriction. So whenever there is vasoconstriction or intense vasoconstriction, it leads to the increase in total peripheral resistance. So these combined effects are actually contributing to the hypertension. And the last one we have is not the least, but this is the stress. Stress is very common, and whenever we are in a state of stress, our body do a sympathy to control that stress, and in response to that stress, our body releases catecholamines, and those catecholamines are actually causing a lot of trouble to the body. Actually, what happens whenever you are stressed, if anyone of you have experienced this, your heart rate goes up and you have a tachycardia type of symptoms. So what happens that it usually goes and affects your nodal SA nodes, nodal tissues, and also it affects your deposition of the calcium and all those activities, and increasing your contractility of the heart. And the periphery, what does with the vessels, they are causing vasoconstriction, acting on the beta 1 receptors, and these are all the mechanisms which are actually contributing into the hypertension. If you guys are clear, then we can move on to the next section, because I know you guys should be clear about these concepts, because we have already explained these basic concepts. Nice, everyone is clear. That is very nice. And if you still have problem, I can explain it. Okay, that's nice. That is very nice. Good. So moving to the next, we have so we have secondary hypertension, and this is really important hypertension. Mursal Akrami, which language do you want me to explain it to you, please? If you can please clearly tell me that I can explain in that specific language. Mursal, please tell me, write me. Okay, I'll explain it in Dari. I think both of them are requesting to be explained in Dari. I'll go back and I'll explain it in Dari. متوجه شاین یگان مکانیزمایی است که اونا چی میکنن؟ contribute میکنن the hypertension. یکی از اونا که از ایج است. اون مردمی که عمرشان زیاد میشه، از 50 تا 60 سال میشن، در اونا یگان مکانیزم است که در اونا در جسمشان یگان چیز به نام کالژن زیاد میشه. او چی میکنه؟ وقتی که کالژن زیاد میشه، او ارتجاعیت چیز زیاد میکنه یک وسیله. وقتی که در اوج کامپلاینس ارتجاعیت زیاد میشه، کامپلاین کم میشه. که کامپلاینس کم شوه، در اوج فشار زیاد میشه، توتال پریفرال رزिस्टنس زیاد میکنه. دیگه اونمو باعث ازی میشه که چی کنه؟ هایپرتنشن کاز کنه. و دیگه که از چی میشه که ایورتیک ستینوسیس یک دیگه بسیار کامن است در اولد ایج که در مریضای که عمرشان زیاد باشه. در اوج هم چی میکنه؟ هارت بسیار کوشش میکنه که یک فشار بسیار بالا را باید روبرو میشه، باید اونمو فشار کوشش کنه که از او فشار خود بالا ببره تا که خون پمپ کنه به اطراف. دیگه این دو عموما چیزی است که چی میکنه هایپرتنشن. و دیگه چی است که در اولد ایج وقتی که عمر ما زیاد میشه، یگان استرس مکانیزمز و دیگه مکانیزماست که و چی میکنه می آرتریز ما که است در اینا یک چیز به نام آرتریوسکلروسیس که چیا نیرو میکنن بلاد وسلای ما را. وقتی که یک بلاد وسل بسیار نیرو شوه، او هم باز چی میکنه؟ علت زی میشه که باید بلاد پرشر زیاد کنه. دیگه چی از سموکینگ است. در سموکینگ هم بسیار زیاد همون میگه که خودش نیکوتین داره و نیکوتین که اسمش برای قلب عمل میکنه و چی میکنه؟ کانترکتیلیتی قلب زیاد میکنه که همون انقباضات است، او را زیاد میکنه. و دیگه اسی نوت همون نود که در کاردیاک تیشو است، او را بالای از او عمل میکنه، هارت ریت بالا میبره. دیگه ای اردو چی میکنه؟ کنتریبیوت میکنه به هایپرتنشن. سیدنتری لایف استایل اونمو مردمی که و کدام اکتیویتی نمیکنن، ورزش نمیکنن، فقط در خانه افتیدن، میخورن، مینوشن و دیگه کدام کار نمیکنن، وزنشون بسیار زیاد است، اونو مردم هم پرون به چی هستن؟ به هایپرتنشن هستن. اوبیسیتی، اونو مردمی که وزنشون بسیار زیاد است، بی ام آیشون از 25 بالا است، دیگه اونو مردم هم زیاد به هایپرتنشن مواجه هستن. و علتش چی است که میگه در اوبیسیتی چی میشه؟ که در اوبیسیتی یک مکانیزم میگن که در اوج به نام لپتین یک هورمون است و یک به نام گریلین هورمون است. گرینین که است چی میکنه؟ وزن آدم زیاد میکنه و لپتین که است آدم چی میکنه؟ وزن کم میکنه. دیگه وقتی که گریلین زیاد میشه، او در جسم یک مکانیزم که properly clear explain نشده، توسط زو چی میکنه که total peripheral resistance زیاد میکنه، TPR. در کدام وسلز که هستن در اونا لیول چیز زیاد میکنه. یکی علتش است و دومش است که در آرتریز که است پلاک فورمیشن زیاد میشه، آرتریز نیرو میکنه. یک علت دیگه است که کنتریبیوت میکنه به هایپرتنشن. و یک چیز دیگه داریم به نام الکل. الکل هم بسیار مکانیزم است که سیمپاتیک نروس سیستم اکتیویت میکنه که از او اپینفرین نورپینفرین میره بالای قلب عمل میکنه و بالای عضلات عمل میکنه و بالای شریانا عمل میکنه. وقتی که عمل میکنه التیمیتلی او چی کاز میکنه که بلاد پرشر کاردیاک اوتپوت اونمو چیزا را که ما گفتیم بیسیک مکانیزم را کلش بالا میبره، در کاردیاک اوتپوت زیاد میشه، توتال پریفرال رزिस्टنس زیاد میشه، التیمیتلی بلاد پرشر زیاد میکنه. و یکی به نام استرس که از دایی ما متوجه شده باشین وقتی که ما زیاد استرس میگیریم در وقت یگان هورمونا ریلیز میشه که او را به نام کتاکولامین یاد میکنن. اونمو هم چی هستن؟ اپینفرین نورپینفرین است. وام میرن بالای قلب و بالای زمو عضلات و بالای زمو شریانا که از عمل میکنن و بلاد پرشر بالا میبره. دیگه انشالله که این چیزا فهمیده باشین. اگر فهمیدین که ما پیش بریم. خب انشالله که فهمیده باشین این قدر کدام کانسپت مشکل نیست. درست.
Sir, one question, just one question.
Yes.
Sir, you previously said that increase intracellular calcium level that increase vascular contraction and also in the activation of RAS system. It was due to which risk factor? I just noted their stress, but I think it's related to stress or not.
I think you are asking about increase intracellular calcium amount, right? Are you asking this one? Yes. One is alcohol. In alcohol, whenever there is a lot of alcohol consumption, they increases intracellular calcium concentration, and that leads to a contraction of the blood vessels and myocardial tissue. And the second thing is obesity. In obesity, what happens that if there is one cell, there are less number of the cells of calcium releasing cell like that they have sarcoplasmic reticulum. But in obesity, you have more number of cells. Like you can have 5 or 6 cells. So these cells, we can say that these are actually called vascular smooth muscle proliferation. So these smooth muscle are actually proliferated, and when they are proliferated, there are a lot of smooth muscle cells, and they are releasing a lot of smooth muscle into the sarcoplasmic reticulum. And you know the main ion for contraction is the calcium ion. So that is the reason that they cause contraction of the myocardial cells, increases contractility, and also they are increasing the amount of calcium increases in the blood vessel and causing intense vasoconstriction and increases TPR. So the combined and net effect causes increased blood pressure. Are you clear now?
Yes, sir. Thank you.
Okay, that's nice. So we have next section. We had secondary hypertension, and in secondary hypertension, I have already told you guys that this is 5% of the cases, and they are actually young. Remember this thing: they will be young, less than 25 years of age. They will be young people. They are usually sudden onset. They have severe onset with refractory hypertension. This particular sentence should be in your mind. Number one, they are young. Number two, this is the sudden onset. They are severe. They have severe hypertension and with refractory hypertension. So these are refractory hypertension. I'll explain you in a while. Like there is a patient comes to you, you are putting them on one hypertensive agent, like you put them on AC inhibitor. They are not responding, and then you are going into the combination therapy. You are adding the another antihypertensive drug, but still the patient is not responding. You add on the third antihypertensive, and still the patient is not responding. Whenever you face a situation that you put a patient on multiple antihypertensive drugs and the patient is not responding to you, you have to think of secondary hypertension. If the patient is young, they develop suddenly, and there is severe hypertension, like it is more than 200 and 180 or 190, and suddenly comes to you and says like in 1 or 2 days they develop the hypertension, then you have to think of secondary hypertension. You have to rule out the cause. Okay. And it has multiple etiologies, including renal. We have renal causes, we have vascular causes, we have endocrine causes, and the renal are the more common causes, and we will explain them in a minute. So we have the most common causes are the renal. So you have to understand any patient who comes to you and that patient has refractory hypertension, sudden onset and severe hypertension, then you have to think, and you put the patient on multiple drugs and the patient is not responding to you, you should remember that that patient has any secondary cause and that should be ruled out. Are you clear about this slide?
Yeah.
Okay, nice. So,
Yes, sir.
okay, that's nice. Okay, somebody is asking about refractory hypertension. Refractory means that consistent again and again. A patient is coming to you and you are putting the patient on multiple drugs, but the patient does not respond to you. I'll explain it in Pashto or Farsi that you guys can understand. متوجه باشین یک مریض آمد براتون رفرکتری او را میگه که شما بار او را تداوی میکنین بازم او براتون present میکنه کتا hypertension. You have treated the patient and still recurrent. Yes, you can say that's recurrent hypertension. متوجه شوین یک مریض آمد براتون او را شما یک انتی هایپرتنسیو شروع کردین، یک دوا را دادین اونا ریسپاند نکردن، دوم دادین بازم ریسپاند نکردن، سیم دادین، مالتیپل انتی هایپرتنسیو درگ دادین، اما او مریض بازم بهتر نمیشه. شما باید در ذهن خود بیارین که والا دیجا کدام کاز سکندری کاز است که علت زمین هایپرتنشن همین مریض شده. دیگه شما باید متوجه شوین که باید من این مریض چطور کنم، اینوستیگیت کنم که این پرایمری هایپرتنشن نیست، این سکندری هایپرتنشن است. یکی خود عمرش را یاد داشته باشین، ینگ می باشه، بسیار جوان مریضا می باشن، ممکن خردتر از 20 سال باشن، ممکن 10 سال هم باشن، عمرشان بسیار ینگ می باشه. less than 25 years of age اگه بود دیگه شما سکندری هایپرتنشن در ذهن خود بگیرید و بسیار تیز باشه، بلاد پرشرشون بسیار بالا بره. دو بسیار کامن کیس اورینال کازز است و همیال تشریح میکنم براتون. خب متوجه شوین ما داریم the most common causes are renal. So in renal causes we have the first number is fibromuscular dysplasia, and this is usually common in females. You will have a female patient and young patient, a female patient, and they will present to you with a refractory hypertension, so recurrently presenting to you with hypertension. So you have to think that this is fibromuscular dysplasia. And what happens in fibromuscular dysplasia, let me draw it to you that you guys can understand. These two are having the same mechanism. Okay, see. Okay.
همی قسمت استاد جان یکم فارسی صحبت کنین همی قسمت.
بله ایران ما فارسی براتون تشریح میکنیم. این بسیار مهم است.
تشکر استاد.
خب متوجه شوین ما یک چیز ما براتون گفتم که ما چی داریم، ما به نام فایبروماسکولار دیسپلیزیا داریم. متوجه شوین یک کدنی صحیح است. ممکن بسیار خوب دراوینگ نباشه، خب مقصد شما هدفی است که شما بفهمید. چون ما قلم و چیزم نیست دیگه یک ذره مشکل میشه این دراینگ برام. خب let's suppose this is a kidney and this is your renal artery. renal artery صحیح. حالا ما گفتیم فایبروماسکولار دیسپلیزیا در چی میشه؟ اینی رینال آرتری که است ایرا سایزش بسیار ای دیسپلیزیا از می رینال آرتری میشه. این رینال آرتری است مثلا let's suppose یک نورمال رینال آرتری است، دایی کدام دیسپلیزیا نشده، اما اگر دایی ببینین اگر شما ببینین دایی جو دیسپلیزیا کاس کرده، دیسپلیزیا چرا کم کاس کرده که اینمی I'm really sorry, it doesn't work. خب میفهم لپتاپ ما چی شده، بسیار بخشش باشه یکم. خب میفهمی کار نمیکنه، باشین که ما همین چیز خود یک ذره جور کنم، چیز مشکل داره سر بگیریم. خب ایره متوجه شوین ای که از رینال آرتری است و ای هم از نورمال رینال آرتری. صحیح است نه؟ ای بالکل صاف است، کلیر است، هیچ مشکل نداره. وقتی که دیسپلیزیا میشه، در دیسپلیزیا چی میشه که به این شکل ای لیومنش که است بسیار تنگ میشه. وقتی که لیومن تنگ میشه این باعث ازی میشه که همین بلاد فلو که است توسط طرف کدنی چی شوه، ریدیوس شوه. متوجه هستین این خون اولا یک چیز بود، آرتری بود که قدر کلان قطر داشت و این آرتری که است این دیسپلیزیا شده، این قطرش بسیار نیرو شده، تنگ شده. دیگه دی چی میشه، خون به شکل نرمال حرکت نمیکنه. وقتی که حرکت خون کم میشه چی میشه، همیشه که وقت این کدنی فکر میکنه که والا چی شده، مشکل است، بلاد پرشر که است او کم شده. کدنی را چی فکر میکنه، ری فکر میکنه که والا فشار خون کم شده، والا د ترابل است وجود ما. این چی میکنه، این رینین ریلیز میکنه. چی را ریلیز میکنه، رینین ریلیز میکنه. وقتی که رینین ریلیز میشه، رینین ما براتون پیش پاتویش گفته بودم که او چی میکنه، از لیور یک چیز میه به نام چی، بگوین چی میه از لیور؟ آنژیوتنسینوژن. وقتی که او را چی میکنه، ای د بلاد او هر وقت د بلاد می باشه، د بلاد می باشه آنژیوتنسینوژن. وقتی که او میایه او را به آنژیوتنسین 1 تبدیل میکنه. 1 میره د لیور د لنگز به چی تبدیل میشه، به آنژیوتنسین کنورتینگ انزایم بالایش عمل میکنه. به چی تبدیل میکنه ایرا، با آنژیوتنسین 2 which is one of the potent vasoconstrictor. مهمی چیز است، متوجه همی چیزا باشین که این بازیگان چی داره، مکانیزما داره که یک مکانیزمش چی بود که ویزو کانسترکشن میکرد و بغیر از او چی میکرد، سمپاتیک نروس سیستم اکتیویت میکرد. سیم چی میکرد، EDH ریلیز میکرد از posterior pituitary و دیگه چی میکرد، او آلدوستیرون ریلیز میکرد. ای چی میکنه، واटर ریتنشن میکنه. ای چی میکنه، سودیم پلس واटर ریتنشن میکنه. صحیح است نه؟ ای چی میکنه، ای تیکیکاردیا میکنه، چون کتاکولامینز में ने कंट्रैक्टिलिटी रम इंक्रीज میکنه. वेजो कंस्ट्रक्शन چی میکنه، او چی میکنه، टी पी आर इंक्रीज میکنه. खूब कार्डियक आउटपुट ما گفتیم که मेन आर्टेरियल प्रेशर ما बच्ची बराबर است. گفتیم که मेन आर्टेरियल प्रेशर ما که از बच्ची बराबर است، او برابر است با कार्डियक आउटपुट total peripheral resistance. اینو تو چیز دیگه کلی گی افکت اینم کلی چیزا که است یا چی میکنن، یا افکت میکنن بالای چی، بالای कार्डियक आउटपुट و total peripheral resistance. هر دو کی انکریز چه تو چی میکنه، بلاد پرشر انکریز میکنه. ان شاء الله کی کانسپت فهمیده باشید. کی چیزا فهمیدین؟
بله فهمیدیم استاد جان.
اینمی بسیار مهم است. یکی این مکانیزم است و د چیز که است در رینال آرتری استینوسیس رو براتون تشریح میکنم. در رینال آرتری استینوسیس چی میشه، تقریبا مکانیزمشون سیم است، اینقدر فرق نداره، فقط هم شروعش بفهمین دیگه باز خودتون میفهمین. خب در رینال آرتری استینوسیس که است دو چی میشه که let's suppose we have this kidney, we have this kidney, this is your nice kidney, and we have renal artery stenosis. Let's suppose we have, this is the artery and this is the plaque formation into the renal artery, and this is the plaque. When in normal situation, what happens that the blood goes into kidney normally in very good flow, and whenever there is renal artery stenosis, the renal blood flow decreases. What happens, renal blood flow decreases, and when the renal blood flow decreases, it again leads to the activation of what, renin. It thinks that body is in trouble, I don't have good blood pressure, I have to maintain the blood pressure, so it fire up renin. And when renin releases from the kidney, what happens to the rest of the story? You know that. You know already that there is angiotensinogen. It is converted into angiotensin, 1 and then into 2, which is potent vasoconstrictor and causing all those effects that we have already discussed. So these are the basic 2 mechanisms which are causing leading to the development of hypertension and renal artery stenosis and fibromuscular dysplasia. Are you clear about this concept?
Yes.
Okay, that's nice.
Yes, sir.
Okay, if still any problem,
Yes.
I can go back and I
No,
can
no.
explain.
No, thank you.
یک بار دیگه تشریح کنین. خوب کی بود نمیفهم.
No, it is so simple.
This is simple, but still we have some students that they have problem. I have to go and explain it once again. Okay, I'll explain it in Pashto, and I know majority of the people know Pashto and Farsi. If you guys understand this, that will be okay. What happens, man? This is your kidney. This is kidney, and this is renal artery. It either go په دې کې دوه حالت کېږي متوجه شي یا بدای چې دا artery چې دا به ډسپلیزیا شي که ډسپلیزیا شي هم د قطر وړوکی کېږي د دې artery او کچېرې په همدغه artery کې پلاک جوړ شي let suppose همدغه artery ده او د دې په منځ کې متوجه شي دلته یو پلاک جوړ شو صحیح ده داسې پلاک جوړ شو دا خو ډېر غټ شو مانه خو کېدای شي چې پلاک ډېر وړوکی صحیح ده مقصد دا ده چې تاسو لیومن چې دی هغه وړوکی کی نو دا پلاک چې جوړ شي دا پلاک څه کوي دا لیومن چې دی دا وړوکی کی په دې کې چې کم بلډ فلو د هغه شي ډیکریز شي رینل بلډ فلو ډیکریز شي چې دا ډیکریز شي نو د تاسو د کډنی چې کم د کنه دا د فکر کوي همیشه زمنګ بوډي کې چې کم بلډ پریشر ریګولیټ کوي هغه کډنیز دي ډیر میجر رول لري رینین انجیوټنسن او الډوسترون سیستم اکټیویټ کوي نو چې کله بلډ فلو کم شي کډنی دا سوچ کوي چې والا زما بوډي چې دا هغه په مشکل کې ده زه باید رینین ریلیز کوم هغه څه کوي رینین ریلیز کوي چې کله رینین ریلیز کی either کچيري فایبروماسکولر ډسپلیزیا یا رینل آرټری سټینوسیس د دوړو حالاتو کې رینل بلډ فلو ډیکریز کیږي د کوم رینل بلډ فلو ډیکریز کیږي هغه کوم رینل بلډ فلو ډیکریز کیږي په دوړو حالاتو کې چې کیږي رینین ریلیز کیږي چې کله رینین ریلیز شي نو د رینین انجیوټنسین الډوسترون سیستم پترو باندې چې کوم میکانیزم ما تاسو ته مخکې تشریح کړ د دې پترو باندې هغه څه کوي هغه زی ویزو هغه کوي ویزو کنسټرکشن کوي د زړه قلب چې کوم کنټراکټیلیټي دا غزياتې ای ډي ایچ ریلیز کوي واټر ریټین کوي سوډیم او واټر ریټنشن د الډوسترون په تر باندې کوي دغه ټول میکانیزمونه چې دي کمباین افیکټ کوي په جسم باندې او دوی چې کوي بلډ پریشر انکریز کوي نو دا چې دا خو ټمپرری نه ده کنه دا پرمننت دا خو سیګریټ سموکینګ نه ده چې ته بند کې او دا هغه شي د تاسو هغه بهتر شي یا الکول خود نه دي کنه چې تا الکول خدای نه خاصه سو الکول سکي او هغه بند کی او دغه سره دغه بلډ پریشر امپروف شي یا دای چې کوم داسې سټرس لري هغه سټرس مینیج کینو هغه شي نو دا چې دا پرمننت تر سوچ د ټریټمنټ نه کوي نو دا چې کیږي دا د تا بلډ پریشر همیشه ریفریکټری انکریز کیدل ځکه ته ورته څومره دوا هم ورکې نو هغه دوا به ټمپرری ډیکریز کی خو بیرته به انکریز کیږي نو متوجه شي دا چې دا باید د ټریټمنټ شي دا غنه ورسته دا کی ان شاء الله چې سر بم په باندې خلاص شوی دا یو میکانیزم بل میکانیزم چې کوم ده بل میکانیزم ګوري یو ډایبټیک نیفروپاثي دا او بل چې دا پولیسیسټیک کډنی ډیزیز دی په دوی کې څه کیږي دوی کې دا سیخه چې ګوري زه تاسو ته دام ډراکوم چې تاسو په باندې پوښي لیټ سپوز دا چې د تاسو ګلوميرولس او په دې کې وخت چې کله پولیسیسټیک کډنی ډیزیز دی د کې شي د کې لیټ سپوز دا کډنی او دا سیسټس لري دغه سیست چې دی کنه دا کوز د دې کېږي چې دغه کم ګلوميرولر بیسمنت ممبرین چې کم دا کنه دا چې کی جی بی ام ورته وي دا چې کی ډیمیج کی او دا په پولیسیسټیک کډنی ډیزیز کې کیږي او دا په هغه کې کیږي په ډایبټیک نیفروپاثي کې کیږي let's suppose the renal blood flow the renal arteries دي صحیح ده خو د نورمالي څه کیږي چې دلته فلټریشن کیږي صحیح ده کنه دغه فلټریشن چې دا باعث د دې کیږي چې ټول مواد چې دغه فلټر کی او په یورین کې بهر راوځي او یا دای چې بیرته بلډ سټریم ته جذب کی نو په نورمالي پاغه کې چې کیږي چې دغه بیسمنت ممبرین چې کوم ځای کې فلټریشن کیږي دا ډیمیج شوی ګلوميرولر بیسمنت ممبرین هم په پولیسیسټک کډنی ډیزیز کې او هم په ډایابټیک نیفروپاثي کې په دوړو کې دا ډیمیج شوی چې کله دا ډیمیج شي کنه نو دا چې کوي دا کوز د دې کې چې جی اف ار ګلوميرولر فلټریشن ریټ چې کم دی هغه کم کی چې کله هغه کم شي کډنیز د سوچ کوي چې ولا مشکل د وجود کې کوم مشکل د چې زما فلټریشن کم شو نو هغه چې شي کوي اگین هغه میکانیزم د چې هغه رینین ریلیز کوي چې کله رینین ریلیز کی هغه ټول میکانیزمونه چې ما تاسو ته مخکې تشریح کړي هغه په ترو باندې شي کوي دوباره بلډ پریشر انکریز کیږي نو په دې کې مین علت چې دا په polycystic kidney disease او diabetic nephropathy کې په دې کې دای چې glomerular basement membrane damage جی اف آر ډیکریز شي او چې کله جی اف آر ډیکریز شي هغه چې کېږي باډي داس فکر کوي چې والا ټربل ده رینین اکټیویټ شي چې کله رینین اکټیویټ شي نو بیا راس سیستم اکټیویټ شي چې کله راس سیستم اکټیویټ شي هغه سرټن میکانیزم سي دی هغه په ترو باندې بلډ پریشر هم انکریز کوي او کارډیاک آوټپوټ سټروک والیوم او ټوټل پریفرل ریزिस्टेंस انکریز یا بلډ پریشر انکریز کی نو دا چې د مین میکانیزم د پچیشي کې ډایابټیک نیفروپاثي کې او بل پچیشي کې پولیسیسټک کډنی ډیزیز کې پوښ په باندې اګه نه فهمیدم کې د دریم برتون تشریح کوم
یه متوجه شدم استاد
بهترین
استاد اگه بعدی تشریح کنید خوبتر میشه
خوب تشریح می خب متوجه شوین یک چیز داره ما به نام یا دو چیزا رو ما دیگه تشریح میکنیم یکی از پولیس دیابتیک نفروپاتی
No,
خب یک چیزی که از اون میگیم دیابتیک نفروپاتی دیگر میگیم پولیسیستیک کدنی دیزیز خب در دیابتیک نفروپاتی و در پولیسیستیک کدنی دیزیز چی میشه لیت سپوز ایچی است ای گلوميرولاسس باشی که میگه خب یکی از glomerulus ازیر فانکشن از چی است ای فلتریشن میکنه ای چی میکنه فلتریشن وقتی که خون میاد ای ساحه از اینجا تیر میشه از این ساحه گرده دمی گلوميرولس که از اینجا چی میشه ای فلتر میشه اون چیزایی که ضروری است او خون میگیره جذب میکنه و اون چیزایی که غیر ضروری است توسط یورین بیرون میکشه خب اینجا چی میشه در حالت که دیابتیک نفروپاتی باشه و پولیسیستیک کدنی دیزیز باشه اینی که امی ممبرین که است اینمی ایره چی میگه جی بی ام گلوميرولر بیسمنت ممبرین ای چی میشه ای دمیج میشه وقتی که ای دمیج شوه ای چی میکنه که ای پراپر فلتریشن کردن نمیتونه ای چی میکنه جی اف آر دیکریز میکنه وقتی که جی اف آر دیکریز شد او کدنی فکر میکنه که والا د جسم کدام مشکل است که جی اف آر دیکریز شد حتما بلড پریشر که است چی است کم شده دیگه ای چی میکنه امو پروتکتیو میکانیزم که داره امو آرمی رکی داره امو آرمی خود چی میکنه اکتیویت میکنه او آرمی زو چی است او فوج چی است او رینین است وقتی که رینین اکتیویت میشه رینین چی میکنه رینین میره راس سیستم اکتیویت میکنه رینین انجیوتنسین آلدوسترون سیستم باز او سی چیزا است که یکی آلدوسترون است یکی هم ای دی اچ است و یکی هم دیگه چی است دیگه هم ویزو کانسترکشن است که توسط انجیوتنسین 2 میشه ایکولی چیزا که اکتیویت میشه کمباین افکتش چی میشه کمباین افکتش تی پی آر انکریز میکنه و دیگه چیه کاردیاک آوتپوت این دو دانه که انکریز شد بلড پریشر چی میکنه انکریز میکنه امید است فهمیده باشین به چیز این مهم است امی مهم کازای این چیز است سکندری هایپرتنشن اگر اینو بفهمین دیگه براتون حلوا میشه ان شاء الله که فهمیده باشین
yes.
That's nice. Okay.
Thank you very much, sir.
You're welcome. No problem. So this is actually our. These were actually our renal causes. We had fibromuscular dysplasia. We have renal artery stenosis. we have diabetic nephropathy and polycystic kidney disease, and we are all done. So we are moving to the next section. Moving to the next section, we have, okay. What happens? So the second, we have endocrine causes. So the second causes are endocrine causes. So endocrine causes, what we have some of the important endocrine causes, and one of them is hyperaldosteronism. This is our hyperaldosteronism. And then we have بله
امی چارالات که نام گرفتین استاد یعنی در کلی امی آلتا پیدا شه و باز باعث میشه که فشار بلند بره.
بله ضروری نیست که هر چهارش باشه همزمان. یکی ممکن فایبروماسکولار دیسپلیزیا باشه، ممکن رینال آرتری استینوسیس باشه، ممکن دیابتیک نفروپاتی باشه. مطمئن هستین یک نفر که او شکر داره او پرون است به دیابتیک نفروپاتی، ممکن دو دیولپ شود. دیگه دونو مریضایی که شکر دارن اونو مریضا ممکن دیابتیک نفروپاتی داشته باشن، میرن فشارشان بالا میبره. و یا ممکن یک مریض است که او پولیسیستیک کدنی دیزیز داره. دیگه هم مهم نیست که کل علتا در یک مریض پیدا شود، اما یکی از این علتا باعث ازی میشه که فشار خون بالا ببره.
تشکر استاد.
خواهش می‌کنم. خب ما داریم یکی علی او کازایی بود که او از رینال می آمد. صحیح است نه؟ اینجا چی است؟ اینجا اندوکراین کاز است. و یکی از اونو کازا که اسو چی است؟ هایپرالدوسترونیسم است. دومش چی است؟ کوشینگ سندروم است. دیگه فیوکروموسایتوما است. هایپرتایرویدism است و هایپر پاراتایرویدism است. خب د هایپرالدوسترونیسم چی میشه؟ ایرا ما کون سندروم هم میگیم. خب کون سندروم دایی چی میشه؟ که الدوسترون زیاد میشه. وقتی که الدوسترون زیاد میشه، فانکشن الدوسترون چی بود؟ او میرفت سر کدنی عمل میکرد و از اوج چی را جذب میکرد؟ سودیم و همراهش واتر. وقتی که سودیم و واتر رو دور جذب کنه چی میشه؟ بلاد والیم زیاد میشه. وقتی که بلاد والیم زیاد شوه او چی باعث چی میشه؟ او باعث زی میشه که وینس ریترن زیاد کنه. وینس ریترن زیاد شود. وقتی که وینس ریترن زیاد شود د قلب پریلود زیاد میشه. وقتی که پریلود زیاد شود او کاردیاک آوتپوت زیاد میکنه. که کاردیاک آوتپوت زیاد شود چی میکنه؟ بلاد پرشر زیاد میکنه. دیگه متوجه باشین hyperaldosteronism causes sodium and water retention. It increases blood volume, increases venous return, and then ultimately causes increases preload and cardiac output and increases blood pressure. This is the mechanism of hypertension and hyperaldosteronism. And this is also called Cohen's syndrome. I hope you guys are clear about this.
Yes, yes.
Okay. So once you are clear about the basic concept, I think this is not a difficult deal for you guys to understand. The main thing is if you guys know the basic physiology, you can easily correlate it. And this is the beauty of teaching you modular system, that I was again and again insisting to teach you modular system. If you guys know the basics, it is very easy for you to teach you those clinical aspects of that subject. So then we have another thing which is called Cushing syndrome. What happens in Cushing syndrome? In Cushing syndrome, we have hypercortisolism. The cortisol level is increased, and whenever your cortisol level is increased, it activates through certain mechanism, activates your sympathetic nervous system activity. And rest of the story you all know. You guys should understand this. Okay, how the sympathetic activity causes increase your heart rate, increases your stroke volume, and increases your total peripheral resistance, which contributes to the hypertension. Is that clear to you? If you know the basic thing, you are clear, and there is nothing difficult about that topic.
بخشش باش استاد می کورتیزول هم یک خاصیت ضعیف آلدوسترون هم داره.
بله این میره یگان وقت چی میکنه که بسیار در یگان ریسرچ ها گفته شده، کل ریسرچ ها نیست، कम रिसर्चों में कि मुमकिन बॉयस इजी शवा की अल्डोस्टेरोन एक्टिवेट करना व कॉज करना सोडियम एंड वाटर रिटेंशन अम्मो बिस्योर माइनर बिस्योर चीज ह्यूज चीज ना दरा कंट्रीब्यूशन ना दरा मेन कंट्रीब्यूशन इस के सुतवसत सिंपैथेटिक नर्वस सिस्टम एक्टिविटी
درست.
खूब okay, that is nice. And then we have one another thing.
Pheochromocytoma.
We have pheochromocytoma. And what happens in pheochromocytoma?
Epinephrine or norepinephrine.
Yes, this is actually the game of epinephrine and norepinephrine. And whenever you have more epinephrine and norepinephrine, what does it do with the body? It causes activation of speak. You guys speak, please speak to me.
Was a cause of was a construction and by
Well done.
sympathetic activity.
It increases sympathetic activity. It leads to the increased heart rate, increased stroke volume and cardiac output. And also it affects on the myocardial tissue, causes contractility, increases contractility, and also affects on blood vessels and causes increases TPR, increases blood pressure. This is the mechanism. So we have hyperthyroidism. In hyperthyroidism, there is it actually what happens that the metabolism increases in the body, and whenever the metabolism goes up, the demand of the body increases, and the body tries to contribute and meet that body demand. So the demand is actually overcome by increasing the heart rate and contractility, and TSH itself, T2 and T3 and T4 have an effect on myocardial contractility as well. So these are the basic mechanisms that they are activating those systems and contributing to the hypertension. And the last but not the least, we have hyperparathyroidism. In hyperparathyroidism, what happens that there is increase in PTH and calcium, and whenever there is increased calcium, we know calcium is required for
Contractility.
Contraction.
So whenever we have more calcium, we have more contractility, we have more contractility of the myocardial cell, synodal cells, and your peripheral vascular smooth muscles. So in peripheral vascular smooth muscles, they increase your TPR, total peripheral resistance, and in heart, it increases your heart rate, your contractility, and the combined effect is increases the blood pressure. So I hope you guys are clear about the secondary causes of hypertension.
Thanks.
Okay, that's nice. Are you on the same page with me? Okay.
Thanks.
Yes.
Next.
Good. Moving to the next. Okay. So the complications, we have very bad complications, and we are supposed to understand the complications very systematically.
Sorry, sir, we don't have slides.
You don't have slides?
No, sir.
Okay, let me.
Problem is yours.
Slide نداریم استاد ما.
But we had.
مهم میگن که سلاید دارن، شما یک دفعه متوجه شوین مشکل از خودتان خو نیست. یک دفعه همه میگن که دارن سلاید دارن، ممکن مشکل از خودتان باشه در درس.
Yeah, I have.
Okay. There are 2 or 3 other mechanisms that are contributing to the. خو حتما ډیر کسان وي چې موږ سلایډونه لرو. باش ما یک دفعه دوباره کوشش میکنم براتون امی سلاید ها رو اوپن کنم. من یک دفعه کوشش میکنم اگر بتانیم مشکل همه را حل کرده بتانم.
استاد چقدر درس مانده؟
درس خو زیاد مانده. باش
جدی؟ یعنی
نصف درس مانده دیگه تا 19. خب سلاید معلوم میشه حالا برتان؟
سلاید اندوکراین است استاد.
خب من در سلاید میرم، اما یک دفعه بر من شما فیدبک بتین که با کلتان معلوم میشه یعنی.
سلاید داریم، سلاید اندوکراین است، هایپر اولدسترونیزم کوشینگ سندروم است.
ما که سلاید نداریم استاد، مشکل است اینترنت خود ماست. از شما درست است.
خب صحیح خیلی من
شما پیش برین استاد جان.
من پیش میرم که باز وقت بیخینا وقت میشه. حالا
بله.
بسیار مانده رکچر بسیار دراز است. اصلا مکانیزمش بسیار دراز است، باید که همه را بفهمیم، مگه باز مشکل میشه منیجمنتش برام. من اینا کوشش میکنم یک ذره تیز براتون درس بدم. خود کامپلیکیشن ها که ما داریم، نه مهم کامپلیکیشن های سی ان اس است، دو سنترال نروس سیستم داریم، نیوروواسکولار است، کاردیاک است، آیز بالای چشما داره، ممکن بالای واسکولار داشته باشه و رینال داشته باشه. خب د سی ان اس کی چی میکنه؟
بخشش باشه سلاید اندوکراین. سلاید اندوکراین است استاد، از اختلاطات کامپلیکیشن نیست.
باش که من یک دفعه دوباره از پیش کنم، نمیفهمم چی مشکل داره. حالا صحیح شد؟
صحیح شد.
Yes, sir.
الو صحیح شد استاد، تشکر.
خب خیر، یک کار میکنیم که ما تا چیز براتان میرسانم، تا از می کامپلیکیشن هایش میخوانیم، باز تریتمنت و ورکاپ شه بخیر در لکچر آینده براتان درس میدم، به خاطر که تریتمنتش بسیار مهم است.
استاد اگر امکان باشه تریتمنتش هم شب بخونیم اگر مشکل نباشه.
نفهمیدم.
گفتم اگر امکان داشته باشه که شما فرصت
We
داشته
don't have
باشین
problem
تریتمنتش هم
teacher.
خلاص می‌کنیم.
خب فکر کنم محصلین خسته شدن و یا هم مشکل چیز دارن. ما کوشش میکنم اگر کاور کرده تانستم خو امشب براتون کلش کاور میکنم، اگر نه تانستم باز شب دیگه بخیر کنتینیو میکنم.
تشکر بسیار زیاد.
خواهش میکنم. خب when we are talking about the complications of hypertension, we have anywhere we have blood vessel, we have complications. So actually this is the problem of blood vessels, and wherever we have blood vessels, there the complication occurs. So it starts from the CNS into the cardiac, into eyes, into vascular, and the renal system. So in CNS, what happens that they cause a very dangerous aneurysm, which is called Berry aneurysm, and that leads to the subarachnoid hemorrhage. And we have another tiny blood vessels which are branching off from the middle meningeal arteries, which are called Charcot-Bouchard branches, and these branches are causing Charcot-Bouchard aneurysm, and they cause intracranial hemorrhages. And also, whenever there is increase in blood pressure, it leads to leakage of certain fluids into, and there is imbalance between the fluids and the blood vessels, and those fluids are leaking out into the CNS and causing vasogenic edema, and this is actually called Press syndrome. And that Press syndrome, what is actually Press is posterior reversible encephalopathy syndrome. So whenever in Press there is vasogenic edema outside the brain, which is the blood vessels leaking out and causing the edema in the brain. So another type of complication in the brain is hyaline arteriosclerosis. The blood vessels in the brain are narrowed and they are thickened up and causing small infarcts, which are usually called lacunar infarcts, and they are subcortical strokes in the different areas, like in the thalamus, in the brain, and caudate in different parts of the brain. So these are actually the CNS complications. And in cardiac, what we have, I'll draw it that you guys can understand. Let me draw something. This is actually the heart. And in heart, we have a blood vessel. This is a blood vessel in the heart. and whenever it causes plaque formation in this area, and this is the plaque which forms in the coronary artery. This is a coronary artery which is supplying the myocardium, and whenever there is a plaque formation in the coronary artery, it reduces blood supply into that portion of the myocardium, and whenever there is reduced blood supply to the myocardium, it causes decreased oxygen into that area, and whenever there is decrease in oxygen, it leads to ischemia. So the one thing which causes in the heart is ischemia. It could present with NSTEMI, which is called non-ST elevation MI, or it could be STEMI or ST elevation MI, or it could be angina, which you have already studied in your previous lectures. So these are the potential complications in the cardiac myocytes. So these are important complications from your heart. And another complication which it can develop in the heart is, this is the heart, and in heart they usually causes hypertrophy. This is normal right left ventricular wall. They usually causes left ventricular hypertrophy, LVF. And whenever the left ventricle is hypertrophied, it decreases the diameter of the heart. And whenever there is decrease in diameter of the heart cannot receive that preload. It cannot accommodate and expand well. So it causes diastolic failure. So one thing is that it causes ischemia of the heart. The second thing is it causes left ventricular hypertension, left ventricular hypertrophy. And this hypertrophy is due to, there is the blood vessel, and these blood vessels increased their TPR. And whenever the TPR increases, this heart must pump this blood out of the heart with a lot of pressure. So whenever the pressure increases, the heart has to go compensatory changes to overcome this pressure. And when it goes compensatory changes, that compensatory changes is left ventricular hypertrophy. So these are the potential complications that you guys should understand. Another thing we have on the eyes. In the eyes, it usually causes arteriosclerosis in the retinal arteries, and those retinal arteries are actually sclerosing, and then the blood supply reduces into the optic disc and other certain areas of the eyes. So and your retina, what happens that it causes retinal hemorrhages, cotton wall spots, and then you can also get optic disc edema. And these are the compensatory changes that happens in the eyes, which we will discuss later on in a diagram as well, that you can easily understand. So we have some of the vascular complications. They are very dangerous complication. I will explain them in a diagram, but here I will just ask you to focus on them, that you can easily understand from these areas. So let's suppose we have this is an artery. Oh, sorry. This is, sorry. Are the slides visible to you guys?
Yes, sir. It's showing complication
Yes.
of hypertension. No slide is showing.
سيدة هم دغه سيدة متوجه شي کله چې د فارسی میگم که بفهمین پښتو فارسی و فکر ما د انګلیسي اکثره
خب
صحیح متوجه شوین با یک چیز داریم ما به نام ایورتیک دایسکشن. د ایورتیک دایسکشن چی میشه؟ وقتی که فشار بسیار بالا میشه، مثلا این قلب است و ایم ایورتاس، این چند چیزا داره. یکی را میگیم ما سه وصلا داره، یکی را از بیرون اگه شروع کنیم داخلش که است او را چی میگیم؟ انتما میگیم. ما بینش کی است؟ ایرا ما چی میگیم؟ ایرا میدیا میگیم
مدیا
و ادوانتیشیا. این سه چیز است. خب وقتی که فشار بسیار بالا میره این کاز میکنه اینی میدیا را کی چی شوه؟ رپچر شوه. وقتی که رپچر میشه این خون چی میکنه؟ میره در داخل میدیا داخل میشه. صحیح است نه؟ انتیمل تیر میشه، بلد میره و دایسک میشه د وال بلد ویسل که اینمی دایسکشن ما چی میگیم؟ ایرا ما چی میگیم؟ ایورتیک دایسکشن. این بسیار دنجرس کمپلیکیشن چی است؟ هایپرتنشن است. یک چیز دیگه داریم به نام ایورتیک انوریزم. اینمی ایورتا که پایان میه این ممکن چی شوه؟ دایلیت شوه به این شکل. خب اول چی میشه که دیجا ما یک چیز داریم به نام ویزا ویزورم. او چی میکنه؟ دمی خود وال آرتریز که است نه یک خورترک آرتری دیگه می باشه. او را ما چی میگیم؟ ویزا ویزورم. این ویزا ویزورم که است نه وال زمی آرتری را چی میکنه؟ سپلای میکنه، بلد میته برزی. خب وقتی که ای وقتی که اتیروسکلروس میشه دی حرکت خون کم میشه، بلد فلو دیجا کم میشه. وقتی که کم میشه دیگه ای وال دی که کدام دی وال که کدام جایی سپلای میکنه تو چی میکنه؟ او سکلروسیس کاس میکنه و اسکیمیک میشه. وقتی که او اسکیمیا کاس کنه ای چی میکنه؟ خود دایلیت میکنه. وقتی که دایلیت شوه ایرا ما چی میگیم؟ ایرا ما ای بخاطر به یک شکل بالون جور میشه. مو بالون ما چی میگیم؟ ایرا ایورتک صحیح است نه؟ این دو کانسپت فهمیدین؟ خب یک چیز دیگه یک کمپلیکیشن دیگه هم داره. او کمپلیکیشن که سورا ما چی میگیم؟ پورا ما میگیم PAD Peripheral Arterial Disease. خب این چی میشه که وقتی که بسیار وقت هایپرتنشن باشه این کاز آرتریوسکلروسیس میشه که این چی میکنه؟ پلاک جور میکنه دیگه. امو پلاک باعث ازی میشه که با اطراف ما کدام جا اسکلیتال مسلز مثلا لوور لم اپر لم برزو چی میکنه؟ بلد داده نمیتونه که باعث چی میشه؟ اسکیمیک لم میشه. اسکیمیا کاز میکنه د لم و ای میجر کاز چی است؟ امپوتیشن است د مریضایی که هایپرتنشن داره. دیگه ای پتانسیل کمپلیکیشن است باید تیرا بفهمیم. و در رینال چی میکنه؟ در رینال وقتی که رینال هم بسیار مهم است. در رینال عموما چی میکنه؟ CKD کاز میکنه، کرونیک کدنی دیزیز یا اکیوت کدنی انجری برش میگه. دیگه او را چی رقم کاز میکنه؟ متوجه شوین. وقتی که let's suppose ای یک چیز است. let's suppose ما ای یک گلومرولس است و از جام یک آرتری است که میره به این شکلی جمعه و در اینجا که است اینمی تیبیولز است. خب وقتی که بلد میانه در اینجا خورد وسالاس که و میانه نمی تیبیولز که است یاره چی میکنه؟ سپلای میکنه. امی رینال تیبیولز که است. امی تیبیولز چی میکنن؟ به نورمال شکل اینمیا مینتین میکنه. امو بلد پرشر و چیزا را که زیاد چیزا را ابزرو میکنه و سیکریت میکنه توسط زمو. یگان چیزا که ضروری سوره جذب میکنه، یگان چیزا که ضروری نه سوره اکسکریت میکنه، خارج میکنه به بیرون. دیگه وقتی که دیجاس چی میشه؟ اینمی آرتری را اگه متوجه باشی این آرتری چی میشه؟ این رقم تک میشه که ایره رینال آرتریولو سکلروسیس میگه. دیگه بلد فلو توسط زینی تیبیولز که اسو چی میشه؟ کم میشه. وقتی که بلد فلو توسط طرف زی تیبیولز کم شد این چی کاز میکنه؟ تیبیولر سکلروسیس کاز میکنه یا تیبیولر نکروسیس کاز میکنه. یا نکروسیس میکنه یا سکلروسیس میکنه. کیو باعث چی میشه؟ که ای باعث چی میشه؟ رینال تیبیولر ایتروفی که او سایز زیاد چی میشه؟ خورترک میشه که خورترک شو الټیمیټلی چی را کاز میکنه؟ اکیوت تیبیولر انجری و ATN برش میگه یا اکیوت تیبیولر نکروسیس کاز میکنه یا ایرا کاز میکنه و الټیمیټلی اینمی اگه تریت شوه خب پس جور میشه. اگه تریت نشوه وقت زیاد بگیره ای باعث چی میشه؟ CKD میشه، کرونیک کدنی دیزیز. فهمیدین ایره؟
Yes, sir, it's clear.
اوکی گود. خب فکر میکنم زیاد وقت شما را گرفتم. امشب تقریبا 9:30 بجه است. وقتم بسیار زیاد تر شده دیگه. اگر صبح بخیر ادامه بدیم به فکر من بهتر خواهد بود دیگه. اینی یک مرور میکنیم تیزم یک سال ببینین باز بخیر لکچر ختم میکنیم. خب یک چیز براتون گفتم که این باعث چی میشه؟ کرونری آرتری دیزیز میشه. متوجه شوین اینا پلاک جور شده دیگه. امی پلاک گفتیم که باعث چی میشه؟ اینی پلاک است. این باعث میشه که ریڈیوس کنه بلاد فلو را توسط به طرف مایوکاردیوم و اسکیمیا کاز میکنه. دوم چیز ما براتون گفتم که چی میکنه؟ هایپرتروفی میکنه. این را اگه متوجه شده باشین در این ساحه سعی کنین هایپرتروفی شده. وقتی که فشار زیاد میشه قلب به زور پمپ میکنه دیگه کامپنسیتری هایپرتروفی میره. این دوم چیز است. سیم چیز که است که ما براتون گفتم. خب یک چیز دیگه کی بود؟ پورا براتون ایورتیک دایسکشن گفتم اگه متوجه شده.
Aortic dissection.
دیگه ایرا سعی کنین. ای براتون گفتم دیگه که با مختلف چیزا است. یکی را ما گفتیم چی نام داشت؟ آرتری را مختلف سایشه.
یکی وزریوم گفتین وزار اینا رو که aortic dissection ایجاد میشه و انیوریزم گفتین.
ای ادوانتیشیا.
انتیما میدیا ادوانتیشیا.
رپچر در کجا میه؟ ایدنسیکیو زیاد میه. خب
انتما
در انتما رپچر میشه. ایرا سعی
طبقه
کنین
داخلی دیگه انتیما.
میه کجاست؟
با خون میره داخل میدیا.
به طبقه در بین دو طبقه میمانه.
بله گود. دیگه
انتیما رپچر میکنه.
گود. اوجا میره و باعث چی میشه؟
انیوریزم میشه.
دایسکشن
و دوم
دایسکشن aortic dissection.
دیگه براتون گفتم که ویزا ویزورم است که سپلای میکنه وال چی را؟ آرتری را. وقتی که ریڈیوس بلاد فلو شوه او کاز چی میشه؟ بالونینگ میشه. که او را چی میگیم؟ انوریزم.
یعنی انیوریزم میگه میره.
این انوریزم است ان شاء الله.
استاد من دقیق همی وازا وزریوم نفهمیدم کجا هستی چی است.
این ویزا ویزورم که است خو این اصلا وال
وزل سپلای وزلز
vessel over vessel is supplying the vessel. یک وسل است که او چی میکنه؟ یک شریان است که میره کلان شریانا را خود والزمو کلان شریانا را چی میکنه؟ بلاد سپلای میکنه برش، خون میته دیگه. وقتی که دوج سکلروسیس شوه او نیرو میشه. که نیرو شوه او دوج بلاد فلو کم میشه. که بلاد فلو کم شوه باعث ازی میشه که سکلروسیس وال شوه او را ویک میکنه، ضعیف میکنه دیگه. بالونینگ وال میشه.
تشکر.
اینم کمپلیکیشنی که این نیست، اگر امکانش باشه یک ذره تشریح کنیم.
کدام کی را؟
کمپلیکیشنی که برای این اسم میته هایپرتنشن.
خب یکی براتون گفتم که اگر متوجه شده باشین یک چیزی بود به نام بیری انوریزم. صحیح است؟ بیری انوریزم امی میدل مننجل آرتری که در برین میرنه دو که کدام وقتی که بلاد بسیار به فشار میره متوجه هستین که وقت فشار در یک جای بلند میشه و کنسیستنتلی در کل جسم بلند میشه، در یک جای بلند نمیشه و اسپیشلی در اونو ایریاس بسیار زیاد بلند میشه که در اوجه فشار وسلز بسیار خرد است، چون در اوجه چی می باشه؟ آرتریولز می باشه و در اوجه بسیار زیاد کراس سکشنال ایریاش کم می باشه و در اوجه رزिस्टنس بسیار زیاد می باشه. دیگه اسپیشلی در اون ایریا بسیار زیاد فشار می باشه. اینمی فشار اگه بسیار دوامدار بانه د برین به نام د میدل مننجل آرتری به نام بیری انوریزم یا انوریزم کاز میکنه که دایلیت میکنه او را که دایلیت کنه او با وقت زمان چی میکنه؟ او رپچر میشه که رپچر شوه باعث ریلیز بلاد میشه into the subarachnoid space یا که او را چی میگیم؟ subarachnoid hemorrhages میگیم. بیری انوریزم اسپیشلی د subarachnoid space hemorrhage میکنه. و یکی دیگه ازمو میدل مننجل آرتری که از خود برانچکای دیگه برآمده به نام چارکوت بوشارتس انوریزم. چیز که از چارکوت بوشارتس که از خود برانچاس که از میدل مننجل آرتری میبره. وقتی که و دایلیت میشن و باعث ازی میشن که دمو شارکوت بوشارتس که از دونا انوریزم کاز کنن. دو از اونام لیکیج ازی بلاد میشه. وقتی که بلاد لیک میشه او کاز انتراکرینیال همریج میشه. و یک چیز دیگه هم از به نام ویزوجنک ادیما. وقتی که دوجه بلاد ویسلز بسیار زیر فشار میه او باعث زی میشه که ویکنینگ وال شوه. وقتی که ویک میشه وال امو توسط با علت امو فشار که در برین است و چی میکنه که لیکیج یگان فلوید میشه از امو داخل آرتریز due to high interstitial pressure intravascular pressure. و چی میشه که intravascular pressure increase میشه. وقتی که او increase میشه hydrostatic pressure که ما میگیم. وقتی که فشار در داخل زیاد میشه hydrostatic pressure رو push up میکنه fluid into the third space. دغه او میره چی د برین میره که د برین میره او باعث ویزوجینیک ادیما میشه. اینمی ادیما عموما چی میشه د posterior portion of the brain میشه که او را ما چی میگیم پرس میگیم posterior reversible encephalopathy syndrome برش میگه که بسیار کامن از بعد از اینکه اگر prolonged hypertension باشه در مریض. و دیگه یگان لیکونر انفارکت میشه خرد انفارکت که است که د آرتریز که د برین است هایلاین آرتریز باعث هایلاین آرتریوسکلروسیس میشه که هم ریډیوس میکنه بلاد سپلای into the certain areas of the brain و subcortical stroke و انفارکت که خرد میشه د برین. I hope this is clear.
Thanks very much, sir.
You're welcome. Okay, the next thing which we will going to discuss is I'm just focusing on these normal retinopathy and normal healthy eye, and then with the retinopathy which we have. See this. This is the last slide. We will finish today's lecture. We will continue it tomorrow, inshallah, or on in the next day. See, this is our optic disc, which is pretty good, and these are our retinal arterioles and venules, and these are the blood vessels which are normal. These are pretty good and very nicely appearing into the optic disc. So whenever there is high blood pressure consistently, it leads to the microaneurysms. The first thing which happens in the brain is are these microaneurysms. So these aneurysms causes weakening of the wall of the blood vessels in the retinal arteries and leading to the hemorrhages. And these hemorrhages are in the inside the eye. And then we have another thing which we call arteriovenous nipping. These are actually this is the artery and this is the vein. And whenever there is increased pressure in the artery, it puts this pressure on the vein. And when it put pressure on the vein, it causes discontinuation, and there will be a gap between these artery and veins, which will be looking as a AV napping. So these are also a complication of the hypertensive retinopathy. And then you have hard and exudates, and we have cotton wool spots, which are visible in this eye with the with a prolonged hypertension and in a case of retinopathy. So you guys, I hope you guys are clear about these pictures and these basic things.
Thank you very much, sir.
You are welcome. So this is actually at the end of the lecture. This was where we stopped our lecture last time. So here we are starting with the complications. We have ended up with the complications, and now we have the hypertensive crisis. We usually divide hypertensive crisis into two categories, and one we have hypertensive urgency and we have hypertensive emergency. These are the two crucial conditions, and you have to differentiate between these two. Marcel says that I should elaborate every slide. Marcel, we are really sorry. We have already discussed these things in our previous lecture. That's why I'm not going to go into much details of those slides. But since we are now from where we left last time, I'll explain these slides from this hypertensive crisis onward. I'll be explaining things to you, and then you can understand it easily. But if you have any problem in a previous lecture, I can go back to you and I can explain that to you as well. Okay. We have hypertensive crisis, and these hypertensive crises are divided into two categories, right? What are those two categories? Number one, we have hypertensive urgency. So you have to differentiate between these two. What is emergency and what is urgency? You are this is very, very important to understand between these two terminologies. And you can get questions in your exams, and you have to understand them. So we have, okay, so what is urgency? So you have a your blood pressure, which is systolic blood pressure, which is more than 180 millimeter of mercury, but your diastolic blood pressure is more than 180 or 120 or more than 120 diastolic blood pressure, and 180 or more than 180 180 or more than 180 systolic blood pressure. This is actually, but there is one thing, there is no target organ damage.
We can see the slides. There's
You
no,
can't.
there's no
Sorry.
slide.
Okay. Let me check it. I think I have opened my own. This is a problem with computer. I have opened my own slides, and I'm not into the Zoom meeting. Okay, let me check it. Just give me 1 or 2 minutes. I'll share my screen back to you. Is that clear now? Is that visible?
Yes, sir. Yes.
Okay. I'm really sorry for the
Yes.
inconvenience. Okay. So here we have hypertensive crisis, and we broadly divided the hypertensive crisis into two categories. And category number one was the this one, and this was actually the hypertensive urgency. And the second we had is the emergency. You have to understand these basic terminologies. In urgency, what we have blood pressure, which is systolic blood pressure, which is more than 180 millimeter of mercury. Either it could be 180 or more than 180, and your systolic diastolic blood pressure will be 120 or more than 120, but there will be no target organ damage. There will be no sign and symptoms of target organ damage. What are the particular sign and symptoms of target organ damage? Either a patient, like if you start from the head, we had the complications in the head. A patient can present with headache. If a patient has headache and comes to you and has this number of blood pressure and have headache, either the patient has fits, the patient has dizziness, and the patient has polyuria, which is initially a sign of AKI, acute kidney injury. Okay, and a patient has proteinuria, or a patient has blood in urine, which is called hematuria. And either the patient has, if you go to the heart and the complications in the heart, we have already talked about this, that the patient has, if the patient developed MI, the patient will have chest pain, and the patient will have diaphoresis and certain other things, like the patient might present to you with the vomiting. And these are the certain things which are signifying that the patient is in a state of emergency, not in a state of urgency. If you have all these signs and symptoms, and the patient presents with this same reading of the blood pressure, which is 180 by 120, but have these symptoms, we call it emergency. And this is what we call it target organ damage. And if the patient doesn't have these particular signs and symptoms, then the patient is in a state of urgency. In both of these situations, you are not supposed to bring the blood pressure very rapidly. You don't have to bring the blood pressure rapidly down. You have to bring it slowly and steadily. You are not supposed to bring the blood pressure very rapidly down. Okay, so you have to understand this. You must have seen people that they are giving sublingual medications. I'm really sorry. Sublingual medications in a case of hypertensive emergency, and they are bringing the blood pressure rapidly down. So this is not a standard practice. You should understand these basic things so that you are not going to practice it in your own clinical setups or your hospital or your environment. You are not going to harm your patients, right? So these are the basic terms. I'm going to explain it in our national languages that you can easily understand. These are the pretty important concepts that you guys should understand these things. So I don't know what happens to this today. Okay, is that clear to everyone? Are my slides clear to everyone? Slide I'm about malum mesha.
Yes, sir. Yes.
خب یک بسیار مهم است این را باید شما بفهمین. یک خب ما هایپرتنسیو کرایسیس عموما به دو چیز دیواید میکنیم که یکیش هم چی است؟ This is hypertensive crisis. خب به دو چیز ما دیواید کردیم. یکیش ما گفتیم ارجنسی و یکیش هم ما گفتیم امرجنسی. باشه که من یک رنگ دیگه بگیرم که براتون همه معلوم کنه. این را ما گفتیم امرجنسی. خب ارجنسی چی را میگن؟ ارجنسی همون حالتی است که دو فشار خون سیستولیک است او از 180 بالا میره و دیاستولیک است او از 120 بالا یا ممکن 120 باشه و یا از این بالا بره و سیستولیک هایپرتنشن که است او از 180 بالا میره یا ممکن 180 باشه. اما without دو اینی چیز بسیار مهم است که دو target organ damage یا end organ damage کدام ساین و سیمپتومزش نیست. او ساین و سیمپتوم چی است؟ ممکن پیشنت بیای هدیک داشته باشه، ممکن وامتینگ داشته باشه، ممکن دیزینس داشته باشه، ممکن فیتس داشته باشه که این سیگنیفای میکنه که برین مریض که است متاثر شده. خب ممکن بالای چست، چون ما گفتیم که بالای هارت هم کامپلیکیشن میده، ممکن پیشنت برات بیای و او چست پین داشته باشه که سیگنیفای میکنه که پیشنت در ام آی رفته، ممکن وامتینگ داشته باشه، اگین ام آی سیگنیفای میشه، دیافورسیس داشته باشه که مریض میاد چست پین داره همراهش او بسیار عرق میکنه و یا هم او وامت میکنه دیگه. اینی سرتن چیز است، ساینز اند سیمپتومز است که او سیگنیفای میکنه که پیشنت که است ان تارگت ارگان دمیج داره. و یا ممکن مریض است میاد برات میگه که ما چشمای ما خیره معلوم میکنه، درست نمیتونم ببینم. و یا ممکن مریض برات بگه که ما پول یوریا دارم، زوزو یورینیشن میکنم، زوزو یورینم پاس میکنم دیگه. یک دیگه ساین بوده میتونه. و دیگه ممکن مریض بیاد برات بگه که ما فاول سمیلینگ یورین دارم که او بدبو میاد اسپش که سیگنیفای میکنه که پیشین ممکن پروتین لاس میکنه دیگه. این همه چیزا که است کامپلیکیشن هاست که من براتون گفتم که کلی که اگر در برین بره مثلا استروک، اگر در چست بره مثلا دوجی چی میکنه که مایوکاردیال انفارکشن، و اگر در کدنی میره در کدنی چی میکنه که سی کی دی یا اکیوت کدنی اینجری میکنه که امو ساین و سیمپتومز در جایی که میره که اگان مشکلات پیدا میکنه در آیز اگه کدام افکت میکنه اوجا ممکن دیگه. این همه در هر جایی که من براتون گفتم امو کدام کامپلیکیشن های رو که ما گفتیم از اونجا کدام ساین و سیمپتومز معلوم میشه دیگه. او استیت چی است؟ او استیت ایمرجنسی است که دوجه چی است؟ تارگت ارگان دمیج است. صحیح؟ بلاد پرشر سیم از در دویش. فکرتان باشه که بلاد پرشر در دویش سیم است، کدام فرق نداره. فقط و فقط فرقی که است در ارجنسی کی است without target organ damages و در امرجنسی کی است دو target organ damage می باشه. انشالله که کانسپت فهمیده باشه. اگر کچیر تاسو نه پوښتوي او چې تاسو په پښتو کې هم تشریح کوم، دا یو مهمه کانسپټ د په دې باندې خپل سر خلاص کړئ. اوکې نایس نایس ښه ډیره ښه ده. زه سمه ده ښه. خب we are moving to the next slide. Let me clear it first. Okay. So this is important. If you know the complications, you can easily treat that patient, and you can easily okay, somebody says that I should explain it in Pashto as well, so I have to go back into the previous slide. This is متوجه شخه دلته موږ دوه شیان لرو، یو ته وایي hypertensive emergency او بل ته وایي hypertensive urgency. urgency چې دا په دې کې څه متوجه شئ چې په دې کې زمونږ او تاسو د وینې فشار چې دا هغه د 100/100 یا کېدای شي 100 systolic blood pressure به د 100 diastolic blood pressure به د 100 خو او یا کېدای شي چې 100 systolic blood pressure او 100 diastolic، خو یا کېدای شي لدنه ډیری صحیح ده، ددنه کم نه یا بدونه یا بلدنه ډیری. خو د سره چې دا یو شی په یاد وساتئ without د کې چې د ټارګټ اورګان ډیمیج کم ساين او سمپټمز چې دی هغه نشته. صحیح ده، ما مخکې تاسو ته ایکسپلین کړ چې ټارګټ اورګان ډیمیج ساين او سمپټمز کوم وي، په کوم ځای کې چې کمپلیکیشن ورکړي هایپرټنشن، کاغه په سترګه کې، کاغه په برین کې سټروک وشي، کچېرې ایم آی وشي، مایوکارډیال انفارکشن وشي، او یا هم اکیوټ کډنی انجری کوز کی، نو دا ټول چې دی دا د شي دي ساين او سمپټمز دي د ټارګټ اورګان ډیمیج یا اند اورګان ډیمیج. او کچېری دغه ساين او سمپټمز نوي پکې دته بیا موږ سوي دته موږ ایمرجنسي وایو. نو بیا هم بلډ پریشر هغه بلډ پریشر د خو پاغه کې ټارګټ اورګان ډیمیج ساين او سمپټمز نشته، چې هغه ټارګټ اورګان ډیمیج ساين او سمپټمز کچېری پکې وي هغه ته موږ ایمرجنسي وایو، کنه وي هغه ته موږ ارجنسي وایو. صحیح شو، ان شاء الله په دې باندې هم سر خلاص وي. د کې ډیر زیات ام سی کیوز راځي چې مثلا یو کس د 100 پر یا 200 پر 110 بلډ پریشر لري، خو په هغه کې کم ساين او سمپټمز دا غنښت د اند اورګان ډیمیج نشته. تاسو ته به کې د شي ډیر شان به درکړي ماسک هایپرټنشن، یا به درته وي چې مثلا وایټ کوټ هایپرټنشن، یا به درته وي ارجنسي ده، یا به درته وي ایمرجنسي ده. نو تاسو پوه شئ چې چیرې اند اورګان ډیمیج پکې وو نو هغه ته موږ څه وایو، هغه ته موږ ایمرجنسي وایو. که چیرې اند اورګان ډیمیج ساين او سمپټمز نه هغه ته موږ څه وایو، هغه ته موږ ارجنسي وایو. this is the basic difference. ان شاء الله سره خلاص شوی. هو ورزو وړاندې اوس لرو موږ دلته چې ورکاپ څنګه کوو هایپرټنشن لپاره. نو دا شی باید تاسو متوجه شئ دلته. د هایپرټنشن ورکاپ لپاره کچېرې تاسو کازونه زده، if you know the causes you can recognize the cause and you can treat the cause. If you don't know the cause, then it will be difficult for you to diagnose and treat the particular patient. So we have already talked about the renal causes, and we have talked about the endocrine causes and the neurological causes. So make sure that you know all these causes, and then you can order appropriate investigations, and you can diagnose the case and you can treat accordingly. Okay. And you have in renal causes, we have already talked about the chronic kidney disease, fibromuscular dysplasia, and renal artery stenosis, and polycystic kidney disease. And if you have CKD, you have to see for urine analysis. And once you do urine analysis or RFTs, these are the two important things that you can do for a case of CKD. So you have CKD, you do urine analysis, you can see the patient has proteinuria, the patient has hematuria, or these are the things which you can see in a urine analysis. And if the patient has a chronic kidney disease, you know that there will be two things. His or her urea will be high, and the creatinine level will be also high. So these are the two things which we look for. The normal creatinine level is 1.2 or 0.8 to 1.2. If it is more than 1.2, we can say that the patient has kidney disease. So and similarly, urea is if urea goes up, you can see that the patient has kidney disease. So these are the things that you can see. You do urinary, you can do ultrasound USG stands for ultrasonography. So if you do ultrasonography, you can see that the patient has polycystic kidney. There are multiple cysts in the kidney, and you can diagnose the case. If you do arterial Doppler, see, in arterial Doppler, what we do, we can see the blood flow to the kidney. And if you remember from our previous lecture, and fibromuscular dysplasia, what we had, and fibromuscular dysplasia, there was dysplasia of the renal artery, and that was reducing the blood flow to the kidney, and then the activation of those renin and renin-angiotensin system and all that. I'm really sorry, somebody is creating problem. I have to keep it up. Yes. Okay. So you do arterial Doppler, and you can diagnose fibromuscular dysplasia, and you can diagnose renal artery stenosis. So on arterial Doppler, you are diagnosing these two conditions, and on urine analysis and RFTs, you can diagnose this CKD, and you can see for polycystic kidney disease, and you can do an ultrasonography. So these are the basic things that you can order. These are the investigations that you can diagnose your case. Okay. And then what we have in endocrine causes. In endocrine causes, you have Cone syndrome or hyperaldosteronism, you have Cushing syndrome, you have pheochromocytoma, you have hyperthyroidism, you have hyperparathyroidism. So for these particular conditions, you can do serum aldosterone or renin level. You can do sodium and potassium level, because this aldosterone is going to retain a lot of sodium and excrete a lot of potassium. The sodium will be high, and the serum sodium will be high, and your potassium will be low. So the patient will be in a state of hyponatremia and hyperkalemia. So you have to understand these sorry, hypernatremia and hypokalemia. So you have to understand these basic concepts behind and the reason behind you are ordering these particular investigations. Okay, for Cushing syndrome, you have to do 24-hour urinary cortisol, and this can diagnose your Cushing syndrome. This will be high. And pheochromocytoma, you can see this 24 hours metanephrine, which is the end product of epinephrine or norepinephrine, which is secreted by the pheochromocytoma, which is a suprarenal gland tumor. And then you have hyperthyroidism, which can cause, and for that you have to go and see TSH level, and if you see the TSH will be low in a case of hyperthyroidism. And if it is hypothyroidism, the TSH level will be high. So you can see TSH, or also called thyroid stimulating hormone. So this is one of the investigations that you can order for hyperthyroidism. And then you have this hyperparathyroidism. And hyperparathyroidism, you can check PTH, and you can see calcium. So the major calcium regulatory hormone is your parathyroid gland is usually regulating your calcium level. So if you see the PTH level will be high and your calcium level will be high. So these are the investigations that you can order, and you can diagnose a case with secondary hypertension. And also you have neurological conditions, and neurological conditions, we had Cushing triad. Can anybody tell me what is Cushing triad? Can anybody tell me please in the comment section? Okay, somebody is asking how hyperthyroidism causes hypertension. See, whenever there is hyperthyroidism, there is a lot of metabolism going on inside your body, and the main side, this thyroid T3 or T4 actually affect on your cardiac contractility, and also increases your SA nodal conduction. And whenever your SA node works hard, what happens that your heart rate goes up, and whenever your heart rate goes up, your contractility goes up. We have already discussed these conditions before, but unfortunately, I think you were not present there. That's why you don't know the basic concept behind. So heart rate goes up, your contractility goes up, and whenever their heart rate and contractilities goes up, it increases your stroke volume and cardiac output. And that's why these are the two major contributors of your hypertension. That's why it causes hypertension. I hope hopefully you're clear now. Okay. So these are the things. And can anybody tell me about the Cushing triad? What is Cushing triad? And how do you remember this? Bradycardia and regular respiration. Cushing triad increases intracranial pressure in case of intracranial. Yeah, nice. Well done. Good. Good. Let me see. Let me see your answers. You have Cushing triad, Biden pulse pressure. No, you are not in the right place. No. No. Like your answers are pretty good, but I can add up something. Some response to increase in intracranial pressure that results in Cushing triad of increased blood pressure, irregular breathing, and well done. So who says this? Let me point out the name. This was a nice answer. This was one of the nice answers. All of you answered well, but this answer is pretty good. I'm going to read it out loudly that you guys can understand it as well. So I don't know, I can go up and I can see the name who has written this, but somebody said that Cushing triad is a physical nervous system response to increase intracranial pressure. Whenever the ICP goes up, yes, the body does respond. And that response is in a way that we call it Cushing triad, right? And actually what is Cushing triad? It is increased blood pressure, irregular breathing, and bradycardia. You can say that. Yeah, Gulsher, nice Gulsher. You have done very well. Thank you so much. And you can say it in a way that it is actually how I remember this. There is a mnemonic for that, and that you guys can remember it as well. I don't know, my laptop is not in the same page with me right today. It keeps up disturbing me again and again. Let me get to the right place. Okay, see, we have something we call it Cushing triad, and Cushing triad is increase in your blood pressure, number one, and it is decrease in your heart rate, which is called bradycardia. Bradycardia. And you can say bradypnea, like decrease in respiratory rate or irregular respiration. These three are called, this triad is called, everywhere where we have three things all together, we call it triad. So whenever the blood pressure is high, we call it tachy, right? Tachy, brady. Remember this mnemonic. Tachy, brady. Tachy means that there is hypertension, and brady means that there is bradycardia, and another brady means that there is decrease in respiration or irregular respiration. I hope this is clear to you. And for that particular condition, what we do investigation which is called CT or MRI, and you can see what the situation is and what particular situation is going on. And then you can have a stroke, and for stroke you usually what investigation we usually do CT or MRI. And this is actually how you go step by step and diagnose a case of secondary hypertension. I hope this is clear to you now. And you, if a patient comes to you and you give multiple drugs to the patient and the patient is not responding, and hopefully you know how to deal with that patient and how to diagnose that. Inshallah چې په دې باندې هم سره خلاص شوی که څه مشکلې چې زه تاسو ته بیا تشریح کوم په پښتو یا دري کې که چاته کوم مشکل پاتې نو ما ته وایي چې دا تاسو ته بیا تشریح کوم. اگر یکی از محصلین مشکل داره که براتان در دری یا در پشتو، اگر این فکر کنم بسیار آسان است، کدام چیز مشکل نداره که بریم پیش. اوکی. Okay, I'll definitely repeat the mnemonic, and this is the mnemonic. The mnemonic was Taiki, Brady, Brady. Taiki stands for hypertension, right? And then Brady for decrease heart rate, decrease heart rate. And then another Brady is for decreased respiratory rate. The two Bradys are respiratory rate and heart rate, and one TK is hypertension. And this is actually making up altogether the Cushing triad. Hopefully it's clear now. Really sorry. Okay, so moving forward, we have I don't know what happens to this. I don't know, my computer is not a good friend of mine, so it keeps up disturbing me. Let me move forward. Okay. Are we in the same page? Are we in hypertensive collaborative care? If yes, please write me or somebody give me feedback.
Yes, sir, we can see.
Okay, okay. So we have, okay, thank you so much. We have hypertension. How do we treat? We have already talked about these certain parameters which are important. Not only, you don't have to focus on drug treatment. Remember, whenever we get a patient, we are just focusing on the drug treatment, which is not a sole approach for a patient who has hypertension. You have to take in consideration all these parameters, and if you don't focus on these parameters, it is very, very difficult for you to manage a patient of hypertension. Remember that. Remember, guys. I think Ramin is not clear about tachycardia and bradycardia. Man, I was not talking about bradycardia or tachycardia at the same time. But this is something that I told you before, that tachy means hypertension. That is not actually for tachycardia. That's actually for hypertension. That's a mnemonic that you can remember. You can use your own mnemonic. I didn't mean that the tachycardia and bradycardia is in the same time. This is not the thing. I was actually explaining to you that you can remember from that mnemonic that tachy, brady. I mean, tachy means that hypertension. That is not tachycardia actually, right? I hope it's clear to you now, Ramin. Okay, so the collaborative care is you have to do lifestyle modification, and this is really important. Number one, you have to go for weight reduction. Okay, weight reduction plays a very, very important role. And then we have dietary changes, which is DASH diet. DASH diet is very important. This is dietary approach to stop hypertension, which was developed by American Heart Association. And we will discuss it in details. And then we have limitation of alcohol intake, which is less than 2 drinks per day for men and less or equal to 1 drink per day for women. So this is important. You have to limit your alcohol intake. If you get a patient, I'm pretty sure in Afghanistan we don't have number of patients who are using alcohol, but you have to take in consideration you're not working solely in Afghanistan. You must be working outside Afghanistan, so you have to take in consideration when a patient comes to you, you should take in consideration this alcohol intake. And then regular physical activity, you have to advise the patient to do regular physical activity. Avoid tobacco use. This is important to stop smoking. Stopping smoking is very, very important in every particular disease, but especially in development of hypertension, it is one of the major contributory factors. So you should counsel the patient regarding how to quit smoking. And then we have stress management. This is important. And stress is one of the major contributory factors. And we have already discussed these different parameters, how they contribute to the development of hypertension. So you have to collectively and collaboratively take care of these set particular parameters. Okay, and then we have how we do whenever we do lifestyle modification, what happens if we do weight reduction. This is number one modification that we can do in a patient who has hypertension. And once you do weight reduction, like if you reduce 10 kg weight of the patient, you can decrease blood pressure from 5 to 20 millimeter of mercury. This is a major contributory factor. So you should take in consideration these things. Okay, Ramin. Okay. I'll explain it at the end of the lecture in our national language that you can easily understand. Please remind me once again. And then we have DASH eating plan. In DASH eating plan, what the American Heart Association developed this plan for those patients who has hypertension. So they used to give fresh fruits and vegetables, which were 4 to 5 servings for each per day. So you have to increase your fresh fruits and vegetables. This is number one. And number two, you can also increase low fat diaries, like 2 to 3 servings per day, and certain other things like you can say fats and sweets. They should be very limited, not used often. And you can use nuts and seeds and legumes, and these things are really important. Like if you use fish is very good for healthy heart. So this should be still very limited, but not oftenly used. Like red meat, that should be very limited, not used as often as we use it. Like you can use rice, but not as much as we are usually using in Afghanistan. And then other certain proteins and grains. So this is a diet plan for the patient who has family history of hypertension, or who has a hypertension. Actually, they have to adapt this dieting plan. And if they adapt this plan, they can reduce their hypertension from 8 to 14 millimeter of mercury, which is a major contribution. And then we have dietary sodium reduction. If you reduce sodium, but this is not a thing. If you must have seen doctors that they are advising to the patient. You can see, I have personally seen doctors that they are advising to the patient, stop sodium. No, this is not the way. You don't have to ask the patient to stop sodium. Half teaspoon can be still used by the patient who has hypertension, because salt and sodium and chloride are the major hormone, electrolytes in our body. You can't stop using them. You have to use them, but in very certain limited. You have to limit the use of sodium and in these things, or chlorides, and especially sodium chlorides. You can't stop it, but you can reduce it. And if you reduce the sodium in your diet, you can reduce your blood pressure 2 to 8 millimeter of mercury. And a physical activity is very important. You have to ask the patient to do catwalk, and this is important. Not like you have to see either the patient is young or the patient is old age. You know, in the old age, there is risk of osteoporosis and other things, and the patient can't walk too much, and you can say run. But in young individuals, you can advise them to run. And older individuals, you have to tell them to walk. And if they do walk regularly 15 to 30 minutes, they can reduce their blood pressure for 4 to 9 millimeter of mercury. And moderation of alcohol consumption, this is important. You have to reduce the alcohol consumption, and you can reduce the blood pressure 2 to 4 millimeter of mercury. And if you see these numbers all together, this is 50 to 60 millimeter of mercury difference in a patient who adopts these modification in their life. So lifestyle modification has a major contribution to the reduction of blood pressure. Yes, this is dietary approach to stop hypertension. And next, we have drug therapy, and these drugs are actually used in a patient who has hypertension. We will talk about individual drug group later on, but here you can understand just the major classes of the drugs. And we have diuretics, and in diuretics, which is usually used as hydrochlorothiazide. And the initial dose and starting dose is 12.5 milligram per day in OD, once a day dose. And you can titrate it to 12.5 to 25 milligrams in once a day dose. So the starting dose should be 12.5 milligram, and it should be increased to 25 milligram per day. And then we have beta blockers. They are not commonly used, but we can use them in certain situations, and we will discuss them later on in subsequent slides. And that's atenolol and all those drugs which are coming with the LOL. And the initial starting dose is 25 to 50 milligram per OD dose, and you can go to 50 to 100 milligram per OD dose. And then we have these calcium channel blockers. In calcium channel blockers, we usually have two categories. There are dihydropyridine and non-dihydropyridine calcium channel blockers. And the dihydropyridine calcium channel blockers are not affecting the nodal tissues. So, but the non-dihydropyridine are specifically affecting the nodal tissues like the cardiac tissue, and they are affecting contractility and heart rate. That's why you should understand these. And this one, amlodipine, is not, this is actually a dihydropyridine calcium channel blocker, and it usually affects the arterial and venous smooth muscles, and it is a major contributory factors in reducing hypertension. And the starting dose is 2.5 milligram per OD dose once a day, and you can increase this to 5 to 10 milligram per day. And then we have alpha blockers, which is pyrazosine, and you can say there are certain other drugs which are ending with zosine or osine. And this is like, we also have tamsulosin, which is usually used in a patient who has BPH, and that is you can say 2.5 milligram per OD dose, and you can increase this to 4 or 5 milligram per day. And actually you can increase this to 10 milligram per once a day dose as well. And then you have AC inhibitors, and anything which ends with prel, and that's your AC inhibitor. And you can give 1.5 to 5 milligram per OD initiating or starting dose, and you can go to 20 milligram per OD dose. And we have angiotensin 2 receptor blockers, that is losartan, on candesartan and other sartans. So any drug which ends with tan, sartan, that's actually your angiotensin receptor blocker. And you can give 25 to 50 milligram per OD dose, and you can increase titrate it to 100 milligram per day. And this table is very, very important. This is very, very important. You have to understand these, and I'm going to, in subsequent slides, I'll be explaining the some of the situation that we gave drugs according to the comorbidities, and that slide is very important. So you have to understand these doses, the drug categories, and these examples, because this hypertension is very common disease, and all of us have one or two patients at our home who are suffering this disease. So pharmacological therapy, we had A for ACE inhibitors, we have ARBs, we have alpha blockers, and we have B for beta blockers, and then we have C for calcium channel blockers. We have already talked about the dihydropyridine, non-dihydropyridine calcium channel blockers, and then we have diuretics, and these are the 4 classical drug types that we are using for treatment of hypertension. So this slide is really, really important, and you guys should understand these particular drugs. Hamid says that he doesn't have my voice. I think this is your own problem. Most of the people are having my. Is this a common problem? If yes, then please write me in the comment section that I can understand. I think this is not a common problem. Do you guys hear me? Okay, that's nice. So, brother, you have your own problem. You can see it, and if it is interrupting again, this is your own net issue. And I think in Afghanistan we don't have light for a couple of days. Okay, nice. So AC, we have medical management, and in medical management we have ACE inhibitors. Number one, I'm starting from ACE inhibitors because these are the safest drugs that we can use. And I have already told you, anything which starts with pril, like captopril, enalapril, and lisinopril, I usually recommend this drug to my patients, and this is very nice drug, lisinopril or enalapril. I usually give this drug to my patients, and this has very, very significant effect on the especially those patients who have chronic kidney disease or have diabetic nephropathy. In those patients, it has a very good outcome, and you can give it. So we have number one drug, and that drug is AC inhibitor. And AC inhibitor, they are very good in conditions like diabetes mellitus. You can give them in CKD, and chronic kidney disease, coronary artery disease, and heart failure. So this is very, very important. You guys should understand. And diabetes, actually what happens, that there is chances of diabetic nephropathy and CKD as well. So it causes renal modeling. So that's why they are good in a patient who has diabetes or have CKD. Also, in case of heart failure or coronary artery disease, it causes remodeling of the cardiac tissue as well. So you can give these to the patient who has these certain comorbid conditions. But whenever you are giving this drug, AC inhibitor, you have to look for angioedema. If you start these medications, the patient again after a few days, and you can have an MCQ as well. The patient comes back to you with angioedema and dry cough, and this drug, ARBs, angiotensin receptor blockers. And we have already talked about these valsartan. These are the ARBs. And if the patient has problem with, you started the patient who has hypertension, you started up on AC inhibitor, and the patient comes again with angioedema and dry cough, then you have to switch to the ARBs and give him losartan or her losartan or candesartan. Okay, and the second drug type that we have is like we have diuretics. And hydrochlorothiazide is one of the most common drug which is used, and we have this is actually thiazide diuretics, and we have loop diuretics as well, and furosemide is one of our loop diuretics as well. So what happens that they are actually the diuresis means that they are increasing the your they are increasing formation of urine. What happens that they are actually acting on the kidney tubules, and once they are acting on the different areas like collecting ducts on distal convoluted tubules, and they are actually decreasing the sodium reabsorption. And once the sodium is less reabsorbed, this sodium goes out of the kidney, and once the sodium goes, the water follows the sodium. So what it actually do that, these diuretics are actually increasing diuresis. And once the more urine is passed, what happens that your blood volume will be decreased. And once the blood volume is decreased, what happens that the volume, there is no volume of blood in the body, the venous return will be decreased. And once the venous return is decreased, it decreases your cardiac output, and ultimately the hypertension will be managed in this way. So this is one of important drugs in treating hypertension. But you have to see, whenever we are giving these drugs, they are causing hyperuricemia. What it causes? It causes hyperuricemia. So those patients who has gout, you have to be very careful that you do not have to prescribe it to the patient who has gout. So anyone who has gouty arthritis, you don't have to, I'm really sorry, you don't have to give this drug to the patient who has gout or has swelling of Becto. But they are good in other situation. There is one another situation that they are good in. What could be that situation? That is actually they are actually increasing your calcium absorption. Okay, what they do, they increases sodium calcium absorption, and they are depositing that calcium into the bones. So those patients, like old age patient who has osteoporosis, it will be beneficial to the patient who has osteoporosis in old age especially, but you can avoid them in a patient of gout. And we have another type of drug which is actually calcium channel blockers, and we have amlodipine and nifedipine. And these, if you remember these two names, these are the actually dihydropyridine calcium channel blockers. And in those who are non-dihydropyridine calcium channel blockers, they are not actually ending with the pin. Like you can see pyridine, and there is I in E and dihydropyridine as well, and amlodipine and nifedipine as well. So you have to remember it from this I in E. Anything which has I in E in the end, these are these are dihydropyridine calcium channel blockers. And those like diltiazem and verapamil, these are the two drugs which are non-dihydropyridine calcium channel blockers, and they are not ending with I in E. So remember this, I usually remember this from this particular mnemonic. So remember, dihydropyridine, these are amlodipine and nifedipine, and non-dihydropyridine, they are verapamil and diltiazem. So these are actually very important. They are vasodilators, and actually what they do, they increases they actually affect on smooth muscles, especially dihydropyridines. They are on affecting on arterial or venous smooth muscles, and they are dilating them. And once they are dilated, there is no proper vaso or venoconstriction. The venous return will be reduced, and total peripheral resistance will be reduced, and it will ultimately the mechanism that we have discussed earlier, through all those mechanisms, they will decrease blood pressure. And they are especially important to be given in a case of old age. And double A is for African American. these two drug categories like diuretics and calcium channel blockers, you can give them in African American as well, because they are not having much renin production. So they actually, the problem is with their genetic variations, that they are actually having low renin conditions. So these AC inhibitors and ARBs are not effective in those patients who are African American. So in those black category people, you have to give them either diuretics or calcium channel blockers. And the last category of the drug that we can prescribe to the patient are beta blockers. So we have beta blockers, and we have three different categories of beta blockers. Either they could be alpha beta 1 blockers, they can be beta 2 blockers, and they can be not selective like they can also block 1 and 2 as well. And we have other certain drugs that are also blocking alpha and beta both. So these are the categories of the drugs that the way I remember these things are those drugs which are ending from A to N, from A to N, in these beta blocker categories, which are ending starting from A to N, like atenolol and metoprolol and esmolol. These are actually those drugs which are beta 1 selective. These are beta 1 selective. And those from O to Z, from O to Z, like propanolol and timolol, these are actually beta 1 and beta 2 selective, both beta 1 plus beta 2 selective, right? And those who are different, then they're not ending with OLOL, OLOL. There are certain drugs which are not ending with OLOL, right? Let's see, this metoprolol is ending with OLOL, and this drug also, you can say this esmolol is also ending with OLOL. But there are certain drugs like this carvedilol. See, carvedilol is not ending, this is ending with OILOL, not with OLOL. So those drugs which are ending with these, like labetalol and carvedilol, these are actually alpha and beta blockers. These are alpha and beta blockers. And those who are ending with A to N, they are beta 1 selective. And how I remember this, where the beta 1 affects and where the beta 2. So let me explain one thing else. We have something. Okay, if you see heart is 1. So I remember this, that the beta 1 receptors are located in the heart. And if you see, the lungs are 2. Lungs are 2 in number. So in lungs and bronchioles, actually we have beta 2 receptors. So those drugs which are beta 1 selective, they are only affecting on the heart, and those which are beta 1 plus beta 2 selective, they are affecting on heart as well as on lungs. So that that is the reason you should avoid those drugs which are beta 1 and beta 2 selective blockers. You don't have to give them in a patient who has COPD, because you can exaggerate the already existing bronchoconstriction. And also in a case of asthma, you don't have to give it to the patient who has asthma, because you can exacerbate the situation that the patient has. These are the important categories of the drugs. I hope you guys are clear about these basic concepts. And In one other situation, you don't have to give in a patient who has hypoglycemia. And can anybody tell me the reason behind why we don't give the patient this particular drug category like beta blockers to the patient who has hypoglycemia or who are at the risk of hypoglycemia? Can anybody tell me, please? You can turn your mic on or you can write me down in the comment section. If anybody has information regarding this, please write me down. Shazia asks about AA. AA is African American. Okay, if you guys can hear me, please tell me, why don't we give this drug? I have already explained everything to you. This is one thing, hypoglycemia. You guys should tell me, any one of you should tell me, why don't we give this drug to the patient who has hypoglycemia? Why we avoid beta blockers in a patient who has hypoglycemia? If you don't have any idea, please write me in the comment section. No. Why don't we give it? How does it? Well done. Somebody says that is mask hypoglycemia symptoms. How does it masks hypoglycemia symptoms? Do you guys have any information? How does it masks hypoglycemia? No. Okay, this one person is going in a right direction. This iPhone person, he says that it do slower heart rate. Okay, I'll explain it. Okay, no problem. See, in hypoglycemia, what happens whenever a patient is in a state of hypoglycemia, there is a compensatory response by the body. The body does try to compensate that. So whenever there is hypoglycemia, what happens that there is certain sympathetic activity is going to activate that it can normally. No, let me explain it to you. Okay, what happens that whenever there is hypoglycemia, in that situation our body tries to compensate. How it does compensate? It compensates in a way that it increases your heart rate. You can have other certain things which are the ultimate effect of sympathetic activity. So whenever you give this particular drug, like a, you can, the body is unable to compensate through these basic mechanisms. Your heart rate will not go up, you will not flush out, you will not be like behaving the way you should normally behave in a state of hypoglycemia. So that's why it normally beta blockers are causing masking those hypoglycemia symptoms. That's why you don't have to give this to a patient who has hypoglycemia. It also in a case of bradycardia, if a patient has bradycardia, you don't have to give it because it affects actually on nodal tissue, and whenever it affects on nodal tissue, it decreases the heart rate further. So you don't have to give it to the patient because you can kill the patient. That's why all those patients who has decreased heart rate, you don't have to advise them this category of the drug. And they are good in a condition of coronary artery disease, heart failure, and atrial fibrillation. These are the best situation that you can give them. Like you can give them in atrial fibrillation, you can give them in heart failure. And so some categories of drugs are, you like, if you see in heart failure, we give certain drugs. This drug we can give AC inhibitor or ARBs for remodeling of the heart. You can give beta blockers to control what heart rate. You can control rhythm or heart rate. because in a heart failure you have to have a lower side heart rate that it cannot harm the patient further. You can give these drugs in heart failure because the diuretics are actually decreasing burden on the heart, and you can decrease venous return and all those things. So these three categories of drugs you can prescribe them to a patient who has heart failure. They are good in these situations. Okay, so these are the 4 categories of the drugs as we have discussed, and in the situation that you can give them, and all those situations we have already explained, and I hope it's clear to every one of you. Okay, I'll explain in Pashto. Just give me a few minutes, I'll explain that as well. Okay. The spironolactone and all those drugs are coming in a category of the drugs that are, you can say, calcium potassium sparing diuretics. They are coming in this category of the drug, and they are good in those patient who has especially in a patient who has heart failure. You can give spironolactone to this patient, but you have to look for, because in a case of chronic kidney disease, in a case of chronic kidney disease, you can't give these spironolactone category of the drugs because they are sparing the potassium and increasing in a CKD. Always you can see that the level of potassium is already high, so you can give these drugs to those patient who has you can say who has hyperkalemia. Somebody was asking, so I have to explain that. Okay, once again, I'll try to explain it in Pashto, but we have already discussed these things, but I'll try to discuss this in Pashto with you guys. Boy, salute category the drug larumanga yo tamang AC inhibitors wayu. AC inhibitor हमेशा कोशिश कवई चे start da drug न कवई da डेर ज़्यादा safe da सही दा दा हमेशा प चिशी बांधे खत्मेगी da drugs चीदी दे खत्मेगी प prel बांधे no captopril, enalapril, lisinopril, da chidi da tool AC inhibitors di da mang pa komo condition ke workol shi to kachiri o patient ta diabetes agar shakar waleri aw ya chronic kidney disease waleri che gordo mushkil or ta der ziyati ya coronary artery disease waleri ya heart failure waleri dui se ke che da zadakam agar tissues chidi ago remodel kai dobare jodi no da zaka padi certain conditions ke der khadi خو چې کله تاسو دا ډرګ ورکوي نو تاسو کوشش کوئ چې انجیوډیما او ډرای کف ته وګورئ ځکه چې کله چې دا ډرګ ورکوي نو نورمالي بریډیکایننس جوړیږي او هغه بریډیکایننس چې دي دغه چلار دغه کم ایسی انهبیټرز چې موږ ورکو نو دوی د بریډیکاینن چې کوم دی هغه بلاک کوي چې کله هغه بلاک کوي نو لیول اف بریډیکایننس چې کوم دی هغه په هارت کې اپ شي په بودي کې اپ شي چې زیات شي نو دغه نورمالي کنټریبیوټ کوي د انجیوډیما او ډرای کف ته نو همیشه چې تاسو ای سی انهبیټرز ورکوي نو کوشش کوئ چې وګورئ چې انجیوډیما یا ډرای کف ونشته کې چیرې په پیشنټ کې ډرای کف یا انجیوډیما وشي نو تاسو آرپس ورته ورکوي انجیوټنسن ریسپټر بلاکرز ورته ورکوي چې هغه کې لوسارټان او والسارټان راځي او دوم کټګوري د ډراګ چې کوم دا زمونږ هغه ما تاسو ویلې چې هغه څه ده هغه تایازاید ډایورټکس دي هایدروکلوروتایازاید شو فیورسیماید شو لوپ ډایورټکس راغله پوټاشیم سپیرینګ ډایورټکس لکه سپایرونولاکټون شو دا چې دي دا موږ هم همیشه ډایورټکس چې دي هغه په افریقن امریکنز کې ورکو چې ډبل ای مالیکول دلته او اوسټیوپوروسس په کنډیشن کې او هغه خلک چې هغوی اولډ ایج دي ځکه چې دا پوټاشیم چې سوري کلشیم چې هغه ډیر زیات جذبه او بونس ته ورکوي باډي نه نو د افریقن امریکنز کې ډیر زیات خري خو دا تاسو په گاوټ کنډیشنز کې نو ورکو یا کنډیشن چې هغه گاوټ اکسیمیا کې یا یوریا چې کوم دا هغه کې یوریک اسید چې کوم دا هغه زیات کی نو ځکه په پیشنټس کې چې وي گاوټ لري یا ګوتې ډېر زیاته پړسېدلي هغه کې نه ورکول کېږي دا هم دوه رقمه کلشیم چینل بلاکرز لرو چې یو ته وایي ډای هایډروپیریډین او یو بل ته وایي نان ډای هایډروپیریډین ډای هایډروپیریډین چې کوم دي هغوی یوازې سموث مسلز په سیلز باندې چې کوم په ارټیریل او وینس سایډ کې دي په هغه باندې اکټ کوي او نون ډایهایډروپیریډین چې دی هغوی په نوډل ټیشوز باندې اکټ کوي چې کوم په کارډیک ټیشوز کې د لکه سینوټ شو او یا کانټراکټیلیټي چې کوم کانټراکټایل سیلز دي دغه د هارت هغه باندې. خو دا به موږ په کوم کنډیشنز کې ورکو؟ دا په افریقن امریکنز او اولډ ایج کې ډېر زیات ښه دي چې ورکړلی شي. لاست کوم بیټا بلاکرز چې کوم دي ما تاسو ویل چې سرټن درې کټګوري د ډرګس د بیټا بلاکرز دي د موږ سره. یو دی چې یوازې باندې اکټ کوي، یو هغه دی چې په دې دواړو باندې اکټ کوي. خو په هغه چې په بیټا 1 باندې اکټ کوي، بیټا په دې نه یاد ساتئ چې زړه چې ده یو ده، صحیح ده. نو په زړه باندې چې اکټ کوي هغه بیټا 1 دی. خو زموږ لنګس چې دي که فکر کوئ نو لنګس چې دي هغه څو دي؟ 2 دي. نو بیټا 2 ریسپټرز چې دي هغوی په لنګس کې پراته دي. هغه ډرګس چې موږ او تاسو ورکو چې هغوی نو هغه کې چانسز د دې چې هغه برونکو کنسټرکشن هم وکړي، صحیح ده. بیټا 2 ریسپټرز نورمالي لنګس کې چې د برونکو ډایلیشن کوي، خو که چیرې تاسو دا بلاک کوي نو برونکو ډایلیشن چانسز ډېر کمي او برونکو کنسټرکشن چانسز ډېرېږي. نو په هغه کسانو کې چې هغوی د مخکې نه سی او پی ډي لري یا اسما لري، نو هغه کسانو کې باید چې د بیټا 1 سلیکټیو نه ډېر زیات کار واخیستل شي. کمباینډ بیټا 1 بیټا 2 دواړه چې کوم بلاک کوي هغه نه باید کار وانه اخیستلی شي. نو دا او بل هایپوګلایسیمیا کې کله چې موږ هایپوګلایسیمیا ته لاړ شو زموږ شوګر لیول ډېر زیات کم شي، نو په هغه سچویشن کې چې بوډي او ریسپانس ورکوي چې د تا هارت ریټ انکریز کیږي، په تا باندې کومه خوله راځي یا داسې سرټن کنډیشن فلشینګ او دا سرټن شیان دي چې هغه بوډي چې کوم دی اډجسټ کوي چې تا ته پته ولګي چې والا ما ته هغه شوی لکه زه هایپوګلایسیمیک سټیټ کې یم یا پیشنټ په هایپوګلایسیمیک سټیټ کې ده. نو که چیرې تاسو بیټا بلاکر ورکوي نو دغه کم سمټمز چې دي دا سمټمز بیا په وجود کې نه ښکاره کیږي. سمټمز د هایپوګلایسیمیا چې دي دا ماسک کوي. نو دې وجې نه په هغه پیشنټ کې چې هغوی کې ریسک اف هایپوګلایسیمیا زیاتي لکه ډایبیټیک پیشنټس کې باید بیټا بلاکر وایډ شي. او هغه کسان چې هغوی بریډیکارډیا لري مخکې نه هارت ریټ دا ډېر زیات نور هم کمی نو کېدای شي چې نور هم ایگزاجریټ کړي هغه د هارت ریټ د پیشنټ. نو دا سرټن سچویشنز دي. آی ہوپ چې دا به تاسو ته کلیر وي. ها نیکسټ چې کوم دی اوکې فکر کوم یو یا 2 سلایډه پاتې دي. انشاءالله زموږ لیکچر په ختمېدو باندې ده. بیا که تاسو کوم پوښتنه لرئ انشاءالله چې تاسو پوښتنې ته جواب در کوم. نو ما منځ کې تاسو پوښتنو ته هم جواب درکړه، خو بیا هم که چا کوم پوښتنه پاتې نو زه هغه ته هم جواب ورکوم. یو شی یاد وساتئ چې په پریګننسي کې چې دي هر ډرګ موږ نشو ورکولی، دا شی په یاد وساتئ. ګلنور تپوس کوي انشاءالله زه دې سلایډ ته راغلم، زه تاسو ته د پریګننسي کټګوري ډرګس هم وایم. ښه متوجه شئ. نو دا نمونیک چې دا ډېر امپورټنټ دی. هیلدي مامز لو نیفیډپین. نو یاد وساتئ چې په پریګننسي کې یوازې تاسو دغه ډرګس ورکولی شئ. هیلدي نه چې د ایچ نه واخلئ، د ایچ نه واخلئ I'm sorry. ګورئ تاسو په دې ځای کې چې کوم ایچ ده زما دا پوینټر کار نه کوي، دا ایچ هایدرالایزین هیلدي نه لپاره هایدرالایزین، مومز چې کوم دی د مومز لپاره میتایل ډوپا، ایل لپاره لو دی او لیبیټلول، او نفیډپین چې کوم دی د لپاره خپل نفیډپین ده. نو healthy moms love nifedipine. دغه ټول کټګوریز چې لکه هایدرالایزین شو، میتایل ډوپا شو چې دا سنټرلی اکټینګ سمپاتولایټیک سمپاتومایلایټیک ده. نو دا یو شی یاد وساتئ چې دا په پریګننسي کې سیف ده. لیبیټلول چې کوم دا بیټا بلاکر ده، نفیډپین چې د کلشیم چینل بلاکر ده، او هایدرالایزین چې دا ویزو ډایلیټر ده. نو دغه څلور کټګوریز چې دي دغه څلور ډرګس یوازې په پریګننسي کې ورکولی شي. other than these drugs you can give any one of the drugs. So remember, healthy moms love nifedipine, hydrolazine for healthy moms, for methyl dopa love for labetalol, and nifedipine for nifedipine. So these are the 4 drugs which are safe in pregnancy. Other than these drugs you can give any one of them. So you have to avoid ACE inhibitors and ARBs because they are teratogenic. to the baby, so you don't have to give these drugs. So this is our main, these are our main drugs which we can give to the patient who has pregnancy. So these are the 4 drugs. They are mostly asked in the exams, so you have to remember these drugs by heart. And this mnemonic is pretty simple, and you can, I guess you can remember this from this mnemonic. And then the last one we have is hypertensive emergency. In emergency situation, you don't have to decrease the blood pressure very rapidly, that as I have told you before. And the reason for that, I'll explain it here. Decrease blood pressure to 25%. In emergency situation, you have to decrease pressure 25% in first hour. And then you see a patient can tolerate that reduction in blood pressure. This thing which you can is decrease 25% BP in first hour. If the patient can tolerate it, then go and decrease it to 160 by 100. See, not less than 160. You can decrease it to less than 160, 100 in the next 2 to 6 hours, not rapidly again. If the patient still tolerates that reduction in 2 to 6 hours, bring down baseline in next up 2 days. First, how you do, you decrease 25% of BP in first hour, and then you go and decrease blood pressure to 160 if the patient can tolerate that first 25% reduction in blood pressure. Then you have to bring the blood pressure less than 160, 100 in next 2 to 6 hours, not again rapidly. You have to see again the tolerance of the patient. If the patient can tolerate the blood pressure, then you can bring it to baseline blood pressure within next 2 days, not again rapidly. So the reason why we don't decrease blood pressure rapidly, because it may cause, if you see our body is adapted to a high blood pressure, like our brain is adapted to a high blood pressure, your heart is adapted to a high blood pressure, your kidneys are adapted to the high blood pressure. So if you decrease abruptly that blood pressure, you can cause cerebrovascular accident in the brain, you can cause an MI to the patient, and you can cause acute kidney injury, and you can a sudden drop in blood pressure also affects your brain stem, where your center for hypertension is located, and you can cause herniation of the brain stem. So these are actually important things that should be taken in consideration. And most commonly used drug in these situation are nicardipine and labetalol. We use these 2 drugs. Nicardipine is very commonly used in ICU, and this labetalol is also used for treatment of hypertension. And other drugs which we can use is also hydralazine, esmolol, nitroprusside, and nitroglycerines. And you can use all these drugs in situation if the patient is in a state of hypertensive emergency. So remember this, that you don't have to bring blood pressure rapidly down, and in the first hour you have to bring it 25% decrease. If the patient can tolerate it, then next bring it to less than 160, 100 in next 2 to 6 hours. And if still the patient can tolerate it, bring down the blood pressure to baseline blood pressure in next 2 days. And the reason I have already explained it to you. Okay. We are all done. We are all done. Okay. Let me see if. Okay, nice. So we are all done with today's lecture. If any one of you have any question, you can ask me and I can answer to your questions. First, let me stop the recording.